Good morning, everybody. We're going to go ahead and get started. Sorry for the delay. Thank you to everybody who's joining us both online and in person. My name is Tyler Yates, and I'm the State Opioid Coordinator with the Division of Mental Health, Developmental Disabilities, and Substance Use Services. I want to start by acknowledging all our partners with the North Carolina Association of County Commissioners for hosting today's meeting. Thank you to our partners from Division of Public Health, NC Association County Commissioners, and UNC IPRIC for helping bring everybody together. Also want to extend a special welcome and appreciation to North Carolina First Lady Anna Stein. Thank you for joining us today. Thank you for your continued support and dedication to improving the health outcomes for people impacted by substance use across the state. Today's focus, reducing overdose among justice-involved populations, is both urgent and complex. We know that individuals leaving jails and prisons face one of the highest risk of overdose in the community, particularly in the days and weeks following their release. This reflects a gap in continuity of care, access to treatment, and the supports that people need to survive and recover. Across North Carolina, there's a lot of promising work already underway, including expanding diversion and deflection programs, access to medications for opioid use disorder in correctional settings, and strengthening reentry supports. Today's conversations are an opportunity to continue building on that momentum. Just a few reminders before we get started. A water fountain and accessible restrooms, men's, women's, and single stall options are available out the double doors out there, right in front of the registration table. If you haven't signed in, please, if you can, go sign in at that table when you get an opportunity. Snacks and coffee are out in the hall. Please help yourself. Feel free to take breaks as needed. We have a really packed agenda, so just kind of do what you need to take care of yourself. If you have any questions, please ask any of the NCACC staff members. If NCACC staff could raise your hands real quick so folks know who to ask. If you have questions, these are the folks to ask. And let us know if there is anything we can do to help make your visit more enjoyable. And now, without further delay, I will turn it over to the Director and Assistant Secretary for Mental Health, Developmental Disabilities, and Substance Use Services at NCDHHS, Kelly Crosby.
Good morning, everyone. I do not have slides. Is there going to be like a slide for me, Todd? We good? Okay. Oh, that's fancy. You say I'm going to use the remote. Do I point it at something? The right arrow? It's okay. It's just a slide, I think, with my face on it. But my face is right here, so we're good. So good morning, everyone. Kelly Crosby. Thank you for the introduction, and thank you to NCCHCA. Thank you to all the County of Wake. I love coming to this building. As I was driving here today, I actually texted Sarah to say, do you think we could use this building for an all-staff meeting? I love the building. I love the energy. And I love the fact that very close down the road is our new peer recovery cafe. I don't know if you guys know about it, Promise Resource Network. Some of you were probably at the ribbon cutting. The First Lady was there. But I love the fact that downtown Wake County is really supporting people in recovery. I think that's super, super, super exciting. Okay, downtown Raleigh. I said downtown Wake County. So my name is Kelly Crosby. As you heard, I'm the Assistant Secretary for Mental Health, Intellectual and Developmental Disabilities, and Substance Use Services at the Department of Health and Human Services. So I bring you greetings from all of that, from all of our division, and also from our Secretary, Dev Sangbai. It's a real privilege to be here with y'all. I usually get to come and speak every time you guys meet, not every time, but I'm really glad to be here with y'all today. I don't have a lot of slides because I'm going to talk about
all of the work that we have been doing collaboratively with our communities to support people with substance use issues in the justice system. I like to tell folks, because I think it's important from a stigma perspective, that a lot of the reason I do my work is a lot of the reasons other social workers do their work. I have lived experience with both mental health, substance use, intellectual and developmental disabilities, and justice involvement. They're so intertwined, aren't they? Mental health and justice and substance use are often incredibly, incredibly intertwined. So I have that very real experience myself, and I have a very close cousin, and he is what I would call a success story. He's an individual who and I shared a little bit at in another event I'll tell you about earlier this week. He began to use substances during his teen years. His use escalated, of course. He had several brushes with the law, one incarceration, and then a much longer incarceration. And it wasn't until that second incarceration where he went to prison that he got a diagnosis for his mental health condition. He got help and support for his substance use issues, and he is living a wonderful life. He got reentry supports. He has a family. He has wonderful, beautiful children. He has a new grandchild that just turned 1. He owns his own business. But it took all of us, everybody missing all of that, right? Him not getting help very early on the process. There was every opportunity when he was young. And I think about the things that his community and his family tried to do to help him, which are kind of very traditional things. They made him go to church a lot, which is fine, which can be a strength, right, and a protective factor. They moved him to different relatives in different states to try to get him away from bad influences. But the whole time, he was really suffering with an addiction, which we know better now is an organic illness. It's a medical condition. Medications can help. He had organic mental health issues, not even trauma-based ones, but actual organic mental health issues. You'd think you would know, coming from our family, that we do have organic mental health issues. And he needed good diagnosis and treatment. He needed clinical treatment. And that's important. I'm a clinician. I'm always going to talk about clinical treatment. But just as important as that, he needed all those additional life supports to support him after he left incarceration and went home to the community. He needed all those incredibly important recovery supports. And they were very effective, and they helped him live a magnificent life. So, and he's doing great today. Very proud of him. And so I use that illustration to tell you about a lot of our priorities here at the department. Now, hopefully all of you have seen or heard the governor speak about or saw the big, wonderful event we had for Executive Order 33. Everybody see Executive Order 33, I hope? All right. But I want to talk about Executive Order 33. I won't talk about all the parts in it, but it talks about the continuum of care that I would say all of us have been building for a while, y'all. All of us have been building for a while. All of you in your communities have been doing this extraordinary good work to make sure that we have diversion and deflection up front, meaning we have actually a strong crisis system, but that our crisis system, and this is the point we need to strengthen a great deal, our crisis system needs to know how to address people who are having a substance use crisis or an overdose, not just mental health issues, right? So that means that knowing all of our crisis teams know how to intervene, they know how to help in an overdose, they know how to administer naloxone. The facilities that we are supporting across the state for crisis know how to actually do detox and begin induction for individuals for whom medication would make sense or who want to take medication. So we're working on strengthening that system, but overall, just strengthening that crisis system so it is something that law enforcement can trust. It is something that people know about. It is something that people trust, and it can divert people altogether from calling 911 or engaging with law enforcement up front. Okay, so we're trying to work on that system. But we want to make sure, because everybody's always going to call 911, they are. And we know in many cases when folks are using substance use, there may be legal involvement, right? There might be medical involvement. And so 911 sometimes is the best response. And so when 911 goes out, we want to make sure that we have an abundance of co-response models. The co-response models I've had the privilege of experiencing across the state have truly been extraordinary. We fund some of them, but let me be clear, we don't do that work. The work happens in communities. And there are so many extraordinary things happening in counties that we don't fund at all. I had the privilege of going to Watauga County and meeting the sheriff and his team, as well as the chief of police of the city of Boone, his team, and an incredible peer-run organization. And they had the most amazing LEAD program, which involved everything. It involved ride-alongs, so peers who had their own history of substance use and were in recovery would ride along on 911 calls, so they'd go with the officers. They provided crisis respite and housing for an individual in crisis. They provided care to folks who did go to jail, so they would come and visit them in the jail and offer them support, as well as clinical services that the jail was offering, which is really great. They had partnerships with MOUD organizations in their community for folks to get medications for opioid use disorder, and they could transport those individuals if the clinic wasn't close enough. And then they helped those individuals get, have transitional housing, get whatever kind of education or employment supports they needed, help them with their family and rebuild those relationships, and gave them a peer-based recovery community. This was an extraordinary partnership that community has been building over a long time. And that's what we need more of. So again, that crisis system, but also more law enforcement assisted diversion. We need that partnership of peers, substance use professionals, law enforcement, because people do get arrested for low-level crimes, low-level misdemeanors. And we see the data here in North Carolina. We see it across the nation. When people get diverted into treatment, it's extraordinary. It's what needs to happen. The results are amazing in the communities that we're hearing from. I was in Fayetteville the other day with the governor and with Secretary Sangbai. We were talking about the Fayetteville LEAD program. The officers themselves were talking about the program, where again, folks were getting into treatment instead of being arrested. They would get whatever clinical supports they need, whatever recovery and community supports they needed, whatever medications that they needed. And they were doing really well. And they saw much less incidences of folks reoffending or their substance use escalating. So it is a wonderful moment to intervene. So all that stuff on the front end, I cannot stress enough, is a huge priority for us. I mentioned being in Fayetteville earlier this week because at that time we announced in partnership with the North Carolina Harm Reduction Coalition. Are they here? You guys got to be here, right? 7 new law enforcement assisted diversion programs in 7 counties and municipalities across the state. I should have written them down. I don't want to miss any of them. They're all really important. But we're so excited. And we got to hear, it was just absolutely amazing. We had a panel and we had sometimes the sheriff himself, sometimes a major, sometimes an officer, sometimes a chief of police, sometimes a staff, as well as his community partner, who was often a peer. And they would talk about why they even decided to do this law enforcement assisted diversion program and the kind of outcomes that they were hoping for. It was most instructive. I'm on the clinical side, right? Like, yep, I believe people should get treatment. I believe they should get all the help that they need. I believe that is our responsibility to try to make that happen. But it was just absolutely fascinating to hear from the law enforcement officers, to talk about their skepticism, many of them, their absolute skepticism up front of why would we even do this, right? Is it giving people a free pass? I heard that term like many times. Is it giving people a free pass, right? They've broken the law. They need a penalty. And I forget, I told them, none of you were there. Sarah, you were there. What county was that, Sarah? Remember that gentleman who was like, I thought this was the worst program in the world. I thought he was amazing, that officer. I said, we want to get him to do videos for us for law enforcement assisted diversion. He was a delight. Public speaking was not his thing, but I'm so admire him for being there and kind of for sharing his opinion of his real distrust on wariness of the program, but how he has seen it really transform people's lives. So the people he was used to rearresting again and again, were in fact doing really well, thriving in their communities. They were people that he could trust. They were people he had called upon now to help him with other folks who were struggling with addiction. It wasn't an amazing test. He was my highlight. I don't think he knew he was going to end up being the highlight, but he truly was. So super excited. And I have to recognize and thank the people that made that possible. The General Assembly with the Medicaid expansion bonus gave us money to support individuals in the justice system. So we were able to invest $1.5 million in more of those LEAD programs. Okay, so governor says in his executive order, have a better crisis system, have it function well, have it be responsive, have more diversion programs, have more co-response teams with law enforcement. So we are working on all of those, okay? The executive order also says, hey, people will be arrested. They will go to jail, they will go to prison. Department of Health and Human Services work with Department of Adult Corrections and the Department of Juvenile Justice. We're talking about adolescents too. When they are incarcerated, let's make sure that the treatment they are receiving while incarcerated is good evidence-based treatment. That's both mental health treatment, but also substance use treatment. And I know many of you already support things like MOUD in jails. You're the one that goes to the jail, or you are the wonderful chief of police or the law enforcement officers that facilitate that, because I know it's not easy when you're strapped with staff to make the time and the space to support treatment and MOUD in your jails, but I thank you for that. So we're going to keep working on that as much as we can to support. I promise you, if any of you are in law enforcement, I promise you there is a ready and willing and competent provider who's ready to be your partner, and we will support that. We will support it to happen with technical assistance, with as much money as we can. There's Anna. If you don't know Anna, I don't know where you've been living. Anna knows everybody, but she will figure out a way to make it happen, to support you. But we are also working, again, with very strong leadership from our First Lady. I try not to, it's hard not to point at her all the time because she's such a hero. She's really been pushing us, as has the governor, to have a very strong partnership with the Department of Adult Corrections. We know that 50 to 75% of the people who are in prison have serious mental health issues or substance use issues. They just do. And it can be so hard to even staff adult corrections, let alone have enough staff to do good clinical programming and medications in prison. But we are working with them. We're working with them to strengthen the treatment they're providing to people who are incarcerated, and we're working with them on re-entry programs. They're experts in people in carceral settings, the experiences they've had, they've spent time with them, they've evaluated them, they know how treatment is going or not. We are the experts in community-based outpatient care. And so we need to work with them on those transitions. One of the things that we're working on, you'll see in the executive order, is strengthening the TASK program. Anybody here a TASK person? All right. Yay for TASK. Okay. TASK is called out specifically. We have great infrastructure for TASK. We have TASK everywhere. If you don't know what it is, TASK is literally for people who are re-entering after incarceration. I'll say it the Kelly way. The TASK purists are going to be like, well, that's a way to describe it. They help evaluate an individual and then connect them to care, right? Many of them are very trusted partners of community supervision, right? So they're already trusted partners. We have the infrastructure. And what we are working on, though, is improving and strengthening that program. If Sarah has heard me say this way too many times, but you haven't, so I'm going to say it again. I think that is one of the most critical things that needs to happen. If any of you, and I'm sure you all have, right, because you're all in this room, have done a reentry simulation, they're brutal. I'm not kidding when I say I cried. It was a simulation, and I was utterly overwhelmed by the things that I had to do and couldn't do. And I actually started hoping to get arrested. I was like, I don't care. I can't do this. It was a simulation, y'all. It was a simulation. So having someone, us strengthening that program, us embedding peers who've been there and done that in that program, and us making sure that the task force have the resources to connect people to the treatment, housing, employment, family supports that they need is hugely important for us. So we will work, like the executive order tells us, on making that task program really strong. And then, as people are going in the community, we need good treatment everywhere. We do. We just announced 5 FACT teams. Those are forensic wraparound teams. It's hospital at home for folks living in the community. But we're doing so much work to strengthen the availability or provide more availability of MOUD services across the state. How many trucks we have now, Anna? Just 2? How about the 6 in the west? Okay. We'll have 8 trucks very soon. Some of our rural health transformation funding is going to help us get more trucks in rural areas. There's a map. I know Anna's map. We know where all the deserts are, where there's not enough MOUD. So we're working on those deserts right now. And we're going to announce something really soonish about some really cool technology-supported MOUD treatment that's going to help us, because it's hard to find nurses sometimes. It's hard to get dosing done, right? We know that. So we're going to announce some really cool new programs. So again, we can get more MOUD out to our communities. And again, to folks coming out of incarceration, we need to make sure they get whatever treatment that they need, especially access to MOUD, because we know, you know, as experts, the incredible rates of overdose and death for people coming out of incarceration. So what am I missing, y'all? Yeah. Oh, good. And I'm right on time. But those are the things, again, I want to say, I didn't say it at the beginning, but I cannot thank, when you're in my role, like one of the things that a big important part of my job, yes, it's setting strategy, it's executing on things that my bosses tell me to execute on, but all of those things are easier when you have a leader that says, I support this, it is the right thing to do. I am forever grateful for Executive Order 33. I am grateful for the leadership of Governor Josh Stein, because he said behavioral health and public safety is his priority. He has ordered his departments to go out and do this collaborative work together because it's the right thing to do. It is the right thing to do to support individuals who are enmeshed in the justice system at whatever phase, to build the best system that we can to make sure, again, that they and their families live happy and healthy lives, So again, I want to thank you. Everything that I just said, every bit of it is what you do. We visit you, we support you the best we can through legislation and policy and funding, but it's all what you do. So I cannot thank you enough for the work that you do every day for people living here in North Carolina. We are here to help. Tell us how we can help better. But again, just thank y'all for being here today.
Good morning, friends. It is such an honor to welcome you to our beautiful space with the North Carolina Association of County Commissioners, and it just feels extra special because I have so many friends in the audience. And so I am Nidhi Sachdeva. I'm the Director of Strategic Health and Opioid Initiatives. Thank you for the cue. And I have the great pleasure of working with the Opioid Settlement Technical Assistance Team as part of the North Carolina Association of County Commissioners. And I'm here to sort of echo a lot of the words that Kelly shared, and also just give some context of the updates of the opioid settlement, which is one funding opportunity in addition to the state investment in diversion and MOUD in jails and reentry programs, and just give us a chance to actually learn from local programs. And so I'm going to tell you a little bit about one model of providing care and support for our counties that are really committed to doing what they can to create opportunities for people who are leaving incarceration, as well as in our facilities, and just keep them out of places that they likely are not being served as well as they can be. So diversion, deflection programs as well. But I'm going to do some level setting. I know some of you all have seen me sort of traveling the state for the last 3 years and have heard bits and pieces of this presentation before. But for the 150 people that are online, hello, welcome. And just want to sort of, again, ground us in some updates. But the Association of County Commissioners is a nonpartisan group. I'm just going to point out to our mission statement and vision statement a couple different keywords. One is that our association supports and promotes the well-being of all North Carolina counties. And we really take that to heart, in that we are and understand that everybody in North Carolina lives in a county. And so we're here to serve all the people of North Carolina and to make sure that we're all healthy, safe, and doing well and thriving in our communities. And then part of our vision is that we are here to empower 100 counties to work together for the betterment of one state. And I think what's so unique about being in this position is that we get the chance to learn from all of our locals. I think if you're trying to do anything statewide, you've got to go local. And we're really trying to do our best to learn from one another and do the best to connect the dots, because no one person stays within one county boundary, right? We all travel around and enjoy this beautiful state. And so we are doing our best to not only promote the well-being, but also to empower our counties. And so in the moment, we're doing this through the Opioid Settlement Technical Assistance Team, or as OSTAT, as we affectionately call ourselves. But really, our goal is to improve the health of North Carolina counties. And I'll put a little star next to that, in that health to me also means safety and care. And so in the moment, in this time, we're really focused on helping local governments make the best use of opioid settlement dollars to invest in evidence-based programs, really focus in on supporting the most vulnerable in our communities and helping them just navigate the technicalities and the details and the uniqueness that is this funding source. And so I'm joined with my wonderful OSAT team that's in the room. So hello, team. I couldn't do this without y'all, and it's such a pleasure and joy to get to do this with you every day. So OSTAT, essentially, I just want to make sure if you haven't heard or if you're new to the work, we're really here to help local governments through all steps of the process. So the planning phase, the implementation phase, the evaluation, as well as the reporting. And we answer all sorts of questions, everything from small little like, where do I send this email or this report, to existential questions where the problem feels too big, I don't know where to start, what can I do, and where do I go? And so we are delighted to have the opportunity to do that, but we help navigate the NCMOA, which is the Memorandum of Agreement. It's the agreement between the state and the locals. It sort of explains what we can and can't do with the money, sort of puts boundaries and safeties around it, and also gives us really good guidance about where we can have the most impact. And then we just help them through evidence-based strategies and again, sort of telling their story, because the work here in North Carolina is honestly looked at by many other states with envy and appreciation, that we're sort of modeling the work for the nation with the opioid settlements. And I don't say that lightly, and it feels really weird to brag about it, but like, not gonna lie, it's true. So also, we just hit a big milestone. So in 2026, we actually had over 2,600 instances of technical assistance offered to counties. And that's not just like emails and answering questions, but that's site visits, presentations, work sessions, working with county commissioners to really get them to sort of rally around particular strategies and priorities. I mean, it's a whole swath of technical assistance questions that we've just had the great pleasure to be able to engage with them, because they're asking really good questions. All local governments want to do the right thing. They just don't always know where to start, and we're happy to help coach them through that. I'm also would be remiss to say that like we're part of a bigger thing here, right? So OSTAT is only one part of CORE-NC, which is the Community Opioid Resources Engine. This is a really close partnership between the North Carolina Department of Justice, who is litigating still on the settlements, as well as are in charge of compliance and just making sure we stay within the boundaries of the MOA. And I just have to give a shout out, of course, to then AG Stein, but now Governor Stein, and then the continued work of AG Jeff Jackson and his team for just really setting us up for some really good successes in North Carolina. The MOA was such a smart choice, I think. Many other states are fumbling through the process. They don't quite know where the boundaries are. They don't know how to move the money. They don't know where to go. And I think they made some really, really smart choices when they were negotiating the MOA and the settlements, that in North Carolina, we understand that the magic happens locally. They're the folks, you all are the folks that are feeling this the hardest. You all are closest to the solution. So let's get money to you as fast as we can so you can activate and go and do the good work, because you already know what you need. And really respecting that expertise and knowledge. And so the Association of County Commissioners was part of that negotiation at the beginning, which was wonderful. Really appreciated being at the table. And we are just delighted to continue the work with counties and not leave them at the start line, but really to help them get to the finish. We also have our UNC Injury Prevention Research Center partners who are in the room, and they are just such a delight to work with, some of the smartest data nerds I know. But they essentially are our data hub. They collect all of the reports, they manage our website, and really just help us fulfill our promise of transparency and accountability with this money. And then, of course, our very close dear friends and partners at DHHS, who are also technical assistance providers around the settlement. And this work didn't just start with the settlement, right? Like, North Carolina was actually the first state in the country to sound the alarm that poisoning due to medications was a problem. And called CDC down and was like, the data's weird. We don't know what's going on. Come help us figure this out. And epidemiologist Kay Sanford was the one who essentially said, we need to look into this. And so that started the clock in North Carolina to give us a bit of a head start. So we've been doing this for 20 years, Roll. And like First Lady Anna and I remember long nights and days and conversations in my office where we were trying to figure out the first North Carolina opioid action plan to be like, how can we rally folks around this issue and this topic that is literally the leading cause of death for adults under the age of 50, right? But we have solutions. We just got to activate people to do what we know works. And so we've come a long way since those days, but I'm really just delighted that we have come this far and that we're still really committed to doing the things that we know work. So credit to DHHS also for leading us that far. So for folks who don't know, the opioid settlements in North Carolina are split, the big pot. There's about 56 billion from what I remember last counted nationally that's being divvied up to all the states and localities. And so in North Carolina, we're expecting about $1.6 billion so far. There are a couple of settlements, smaller ones that are still in negotiation that will likely finish up next year. And of that $1.6 billion, it's being split. 85% of those dollars are going directly to local governments for all the reasons that I shared. 15% of it is going to the North Carolina General Assembly so they can divvy up in ways that they see fit. This is unique. Most other states in the country have not set it up this way. They either have some big bureaucratic nonprofit or some sort of grant management organization or are still trying to figure it out. And we were the first state to get money out the door, and we're, I think, the first state to be able to show some results already. This is a picture of the North Carolina payment schedule. So there's a couple things that I just want to point out about this picture, but this is how the payments are going to be coming into North Carolina over time. This is really unique. This is an 18-year timeline, started in 2021. So we're used to getting money like little drips and drabs at a time, right? 2 years, 3 years, 5 years. We're like, yay, we got 5-year funding. But in this case, we have 18. And that's a whole generation of money to try to right the wrongs of the past. And what's unique about this, though, is that local governments do not have to spend the money in the year that they get it, and it doesn't ever expire, which means that they can make really smart choices and be really intentional about how they build sustainability into their plans from the very start. The opioid settlements, the national settlements, are a collection of many, many settlements, like thousands of them, right? And so the money coming in is many different defendants. And so what's also unique about this picture, as you'll see, is that it's sort of a spike at the beginning, right? So depending on who the defendant is, they can pay out on different timelines. So like the Walmarts of the world can afford to pay their settlements out in a year, which is where that big bump came from. And then some of the smaller companies had to pay it out over time, which means that we have a chance to really like put in like a good boost at the beginning to say, let's invest in what we know works, set up the infrastructure, hire the right people, get things going, and then see the cost savings that are going to come with all of the good work that's happening. And so the money, the payments coming in will sort of flatten out over time. But again, local governments are being really smart about how they're investing in those dollars and setting up programs that are going to save them dollars and money too, which is very cool. Okay, oh, and one other thing. If nothing else, please go to the website, ncopioidsettlement.org, which is our core NC website. It has all the things, the portal, everything that I'm saying is up there. So if nothing is registering this Friday, beautiful sunshine morning, ncopioidsettlement.org. So what's the point, right, of doing all this work? In North Carolina, we've sort of set this vision that with the opioid settlement investments, we sure hope and expect that all people in North Carolina will be healthier. They'll have connections and supports, connections to supports and services within a culture of care. That's really what is my guiding force. That's what gets me up every morning. This is where I'm headed, and I sure hope you're going to join me to get there, because I'm feeling really optimistic that if we implement the opioid settlement strategies that are available to us, using these dollars in really smart ways and braid it with all these other great investments and resources and the wonderful energy that is the people of North Carolina, we're going to get closer to this. And so the unique thing, what I mentioned before, is that opioids are the leading cause of death for adults under the age of 50. And so we have a cure, which is really access to medications for opioid use disorder. And so the point is we've got to stay focused. We got to stay in the lane of like, let's don't get too distracted, right? And so I think what's also really helpful about the NCMOA is that it's directing us to focus on supportive programs and services that serve people with opioid use disorder and also acknowledge that we're all complicated creatures. We all have many layers of challenges, and that we can also care for the other parts of us. So if we have co-occurring mental health issues and other substance use disorders, that's also good, but we've really got to stay focused on people with opioid use disorder. And so folks who know me know that I say this a lot, but this is my dream on a PowerPoint slide, y'all. And it feels weird to say that, and my brain is not nearly as organized as this slide, but like my hope is that we'll be able to do all of these strategies everywhere in North Carolina. But remember, local governments don't necessarily always know where to start, or they've already made really good progress in certain areas. And so I'm going to go through these strategies really quickly, just to kind of give you a sense and an appreciation for the fact that we are trying to do our best to care for the whole person. So if you also are familiar and have been in this work for a long time, which some of my, at this point, very old friends in the room know, that this might actually look very familiar. It's from the local menu of actions that came out of DHHS tied to the opioid action plan. And that was very an intentional choice. Because again, we've got good infrastructure, we've got good momentum, we've already made really good investments, we know this stuff works, let's just do it in more places. And so really quickly through the list, number one is collaborative strategic planning. We have really good data in North Carolina. We also know that the experiences of people who are being lost in the system or fall in the cracks will be able to tell us much more quickly where the systems are failing them and how we can better fix it and do better by them. And so collaborative strategic planning is really about getting a good, solid infrastructure, the right people doing the work, and listening to people with lived and living experience. Number two, reason why it's at the top of the list is that access to medications for opioid use disorder is the gold standard clinical care. That's that cure that I was telling you about. And so the whole point of this is to get access to medications for opioid use disorder in as many places as we possibly can, and to reduce the stigma around it so that people are much more likely to ask for help when they need it. I've seen really wonderful models, and working with obviously our tried and true opioid treatment programs, our medication for opioid use disorder access within doctors' offices, health departments, EMS programs have been really stepping up and doing some really amazing stuff to do bridge programs.
Good, how are you?
And it's just been really encouraging.
I've decided I'm coming this afternoon.
Okay, cool.
I have time.
Hearing voices.
So many people are going to be there. I would love to connect with just like workers.
Before we can really expect, higher level of recovery from folks. And so we want to do our best to connect people to supportive relationships through recovery support services. We want to make sure they have safe and stable, secure, affordable housing. And we want to make sure that people who use drugs and are people in recovery have opportunities to meaningful employment and a purposeful life, right? And so how do we do our best to reduce those barriers to be able to meet those basic needs and give them an opportunity to support their families and thrive in their own communities? Early intervention is also acknowledging that trauma is really the gateway drug, if you want to be real about it, right? And so how do we do our best to support young people, youth and adolescents, and have caring, supportive adults recognize and notice that, like, this kid's struggling. I want to do my best to say, I'm here for you. Where does it hurt and how can I help you? 7, 8, and 9, which is on the strategy list, is really about crisis response. It's acknowledging that naloxone is sort of bare minimum foundational work. How do we get this life-saving medication out into more places, saturate our communities with it so that we can keep people alive and well? Post-overdose response is acknowledging the fact that people who have overdosed are more likely to overdose again. And so there's a real key pivotal window where we can say, golly, I'm so glad you're still with us. How can I help you? Where can I connect you? Certain service programs, we're about to celebrate our 10-year anniversary, so good to have NCHRC in the house too. Thank you for all your work there. But legalized in 2016, very much about connecting people to services and care. Decades of public health evidence to show that it reduces disease transmission, keeps people from overdosing, connects people to care and treatment better, and just like wraps the person up with so much support. And they've had some really great successes. And then 10 and 11, 12, which is kind of why we're here today, is really focused on, again, focusing on folks that have multiple levels and layers of challenges in involvement with the justice system. We know that some communities have been over-policed and over-criminalized, and so how do we do our best to, again, right those wrongs and get people into the right appropriate treatment and care, rather than sort of getting stuck in the cycle in the justice system. And so 10 is about diversion and deflection, which we'll talk a little bit about more this afternoon. And then focusing on medications for opioid use disorder access within the jail facility, which is similar to 2, but it just has like very unique challenges and just logistics. And then reentry programs, which of course we don't make it so easy for someone to come back home. And so how do we do our best to ease that transition back to community and back to connections in all sorts of ways. So this is my dream on a slide. Pretty cool. I encourage you all to put your dream on a slide. It's fun to come back to every day. So we're focused today on 10, 11, and 12. I get this question a lot, so I wanted to take a little sidestep and answer it. But people are always asking, well, where's the money going and what is it doing? And so in North Carolina, we update this dashboard every quarter. Remember, ncopioidsettlement.org. And so the most popular so far funded strategies of my dream list in North Carolina are these 5. Evidence or recovery support services, naloxone distribution, again, makes sense to start there. Collaborative strategic planning is where we're building a workforce that's really focused on this very unique funding opportunity. Post-overdose response teams, makes a lot of sense. They're literally on the front lines. And then evidence-based addiction treatment. These are the top 5 strategies that local governments are funding so far with opioid settlement money. And you'll notice that the justice-involved population strategies are not so much funded yet. And I can explain a couple reasons why. One, remember, these dollars don't expire. And so there was a big wave of a lot of federal grants and state grants to do justice-involved work. What I have noticed is that local governments are likely to spend those grants down first. The Bureau of Justice Assistance grants, the COSAP grants, a couple other ones, before they tap into settlement dollars. And it's complicated, right? And so that's really why we at the association were like, we need to do a little bit more technical assistance and go in deeper with counties to try to figure out where to go. But you all have probably heard the statistic many times, but people in North Carolina that are leaving incarceration are 50 times more likely to die in the first 2 weeks of being released. So we were like, we really need to focus in on these strategies as best as we can and offer some more support. And so that's what sort of inspired the Opioid Settlement Academy. The Academy as a learning model is not new. We've been doing it in North Carolina for a long time with the UNC Injury Prevention Research Center, but the opioid settlement work is. And so this is a wonderful way for us to take a 6 months focused time. It's sort of an intensive learning opportunity for us to walk through with counties, place-based teams, to go through the process of planning and really getting together to rally around, like, what is our shared vision? What are we even here about? Where are the pathways forward? What players do we need to connect with and get going? And so we've offered now 2 years worth of the Academy. The first year, we offered all 12 strategies. And then the second year, we've really dug into this justice-involved space. And so really appreciate our collaborators at the UNC Injury Prevention Research Center and, of course, our DHHS partners who helped us sort of get this going. But it's been such a wonderful experience to dig in. I'm really excited that you all are going to get to hear from our 5 latest teams. And so this time, justice-involved strategies, local governments got the chance to choose of the 10 and 11 and 12, those 3 justice ones, and say, we're ready to start. We're ready to do this. We want to grow, expand, or begin a new program. We just need a little bit of help figuring out where to start. And we're like, great, come on down. So they're right here in this room, lots of brains, brilliant energy. And we were able to just have that focused time where we could talk about what the evidence is, connect them with other programs, make it feel a little less abstract and more real, and then actually come up with a plan. And so all the teams came up with a strategy map, which if there are some others in the room, this might look similar, like a concept model or a logic model or something like that. But really it's about figuring out, what do we need? What are we going to do? What are we going to have to show for our efforts? What's going to change? And then in the end, what good are we going to do, right? And so we walked them through this planning process. We did a lot of activities, a lot of adult learning work, a lot of just team time so we could get together and really build consensus around some of our decisions, and then come up with a strategy map. And I also would be remiss to say that throughout all of this work, OSTAT is very committed to doing it from a trauma-informed perspective. And so sort of woven into our opioid settlement technical assistance, woven into the Academy, is really these top 6 SAMHSA principles of trauma-informed care. And so we are trying to encourage this in all of the work that we do. And it has sort of dual purpose. One, we want to not only serve our communities better, but we also want to nurture and take care of the workforce that is so compassionate and so committed and also so exhausted, and just make sure that we keep good people in this work. So just want to sort of put that out there. If you're interested, would love to chat with you about it as well. And we're building that workforce, right? Like this is a really unique, specialized funding opportunity. And this is the time where we're activating entire local governments, finance and health departments and EMS and social services and cross-departmental conversations, law enforcement, the jails, all the things, the whole county approach to doing this work. And these folks are amazing. Like you all are just absolutely amazing. I learned so much from you. And I'm just so grateful to have the chance to support you in every way I can every day. Also, North Carolina Association of County Commissioners is such a delighted to be able to host the North Carolina Summit on Reducing Overdose for the third year. We've sort of gone through iterations of it. UNC hosted it in the beginning. Thanks so much. DHHS did it for a while. And then with the coming of the settlement, it just made a lot of sense for NCACC too, because we were bringing in lots of different local partners and sort of broadening the tent or widening the tent to invite more folks into the work. And so save the date, March 9, 10, and 11 in 2027 at the Raleigh Convention Center here in Wake County. And we'd love to have you all there. It's always a good time and we learn a lot, and it's really great to be in the space with you all there too. So save the date, March 9, 10, 11. But don't know how much time we have for questions, but I'm happy to answer so. And then we'll use it as a transition time to get our first Academy speaker up and ready. I've forgotten who it is, sorry. Alphabetical order. Cabarrus, right? Brunswick, oh my gosh, B comes before C. Okay. Cool. Does anyone have any questions about settlement stuff? Or how we can support local governments? Can you tell I was trying to talk slower than I usually do? I get really excited about this work, so I talk real fast. Okay. All right, we will have time for questions afterwards, but I'm so delighted to introduce our friends over from Brunswick County. We're going to go through each of the 5 Academy teams that are participating in the Justice Involved strategy work, and then we'll just hand it off to the next. And then afterwards, we will have questions from the audience. We have 2 microphones, so start thinking of them, and then we'll do a little bit of panel questions at the end if we've got time. But so excited. Please remember, though, that these folks are in the beginning stages of planning for their Justice Involved strategy, which I find that we don't celebrate enough, to be honest. Like we tend to wait till it's done and not necessarily celebrate all the milestones along the way. And the fact that they're getting started, the fact that they're committed to this work, the fact that they're like excited and ready for this plan is awesome. So please welcome our first team.
Good morning, everyone. I'm a loud talker, so I'm gonna have to gauge if you guys start doing this, then my name is Jeremy Seaman, and I am actually the substitute today for Emma Long from the Brunswick County Sheriff's Office, who couldn't travel, but she is online. We've got multiple team members. As you guys can imagine, it's hard to leave the county when you're a part of sheriff's offices, jails. We had some great participants who were a part of that, who weren't able to be here today. So, but I'm really excited to be here. I've been doing work in Brunswick County for 10 years, and I am super excited about recovery in Brunswick County, even more than I was 10 years ago. Didn't know the First Lady was going to be here. So in the first hour of my presentation, telling you how great Brunswick County is, no. Let's talk about it, though. Brunswick County is great. I love it. We do, in fact, had our local WWAY said Brunswick County is the #1 place to move according to U.S. News and World Report. And I do know, because this was just released, we are the number 10 most growing county in the United States of America, which sounds really great unless you're in Brunswick County, right? And unless you're trying to get services in Brunswick County and some of those other things. But we agree that it is a great place to be. Our current population, 181,626, which is almost double when I first got there. We have 19 municipalities, so lots of different places that maybe you've never even heard about, just little small places. But our Brunswick Detention Center has an average daily population of 292, and the average length of stay is 28 days, which is significant when you think about addiction, coming off medications and things like that. Our overdose rates, as you see, with 78 reported overdose rates, but one of the issues is our lack of access when it comes to medical care. So a lot of folks do go to either Wilmington or Myrtle Beach, so it's really difficult to figure out some of our overdose rates because of that. So let's look at our team. Emma Long is who kind of signed us all up. We're her willing bunch. Kenneth Sullivan is our first sergeant of the jail, and we've had really good jail participation. Kenzie Weaver at the Brunswick County Health Department, me, and Alice Anderson with WellPath, who is the nurse at the jail. She's been really awesome as well. And so we have just said this has been a really great experience for us. Let's look at addiction treatment for incarcerated persons, interactions with established strategies in Brunswick County. We have had recovery support services through Brunswick County Sheriff's Office, naloxone distribution through Brunswick County Health Services. They have worked really hard on that and getting naloxone out there. And that's really been for the last decade. And you have seen a drop in overdoses related to that. And then most recently, we did not have a post-overdose response team until 2024, 2025. We just have gotten that through. If you look at some of the plans that Brunswick County has done, we've just gotten our port team going. And then if you look at the vulnerable population, highest risk of overdose and overdose death within 2 weeks post-incarceration, that's true statewide. And in interruptions in MOUD increased the risk of death for incarcerated individuals. When I first got to Brunswick County, every person that came into Brunswick County Jail was detoxed, absolutely, no matter what. They were taken off all their medications, even if they were being prescribed MOUD, anything that they were using that was a controlled substance. Any controlled substance was not coming into the jail. The ARROW program currently provides a behavioral health response to mental health. So that's the program that Emma Long has been in charge of for the last couple of years and does counseling in the jail. Individuals being released are notified of where and how to obtain naloxone through the distribution network. And then we have a port team added to that recently, which has been working with established providers to provide MOUD upon release to create bridges between release and induction with an outpatient OTP MOUD provider when appropriate. Brunswick County has had more overdoses reported than the surrounding counties, New Hanover, Columbus, and Pender, even despite the fact that we do have folks that seek services in the emergency room in other counties. So Brunswick is a large but extremely tight-knit county where people have witnessed the progression of addiction in those closest to them and are passionate about saving lives and encouraging recovery for friends, family, and neighbors that find themselves incarcerated. Our ongoing motivation is to continue to fully utilize the interconnected strategies and address the gaps in services with the A11 strategy, which is the strategy that we requested to be a part of. In conclusion, just kidding, I've got like 5 more slides, but see, in recovery, you need hope. You got to have some hope. So next slide, hopes for Brunswick County. The Brunswick County team is united in belief that every person affected by addiction, especially those involved in justice system, deserves hope, dignity, and meaningful path to recovery. We strive to transform our community response to addiction, strengthen public health, and help our community heal one person, one family, and one future at a time. And we worked on this statement so that we could present this to everyone. To fulfill this purpose, we aim to increase access to MAT services, especially in the jail, but as transitioning out of the jail as well, strengthen community continuity of care, reduce overdose and recidivism, support long-term recovery and stability, and enhance community understanding. Our challenges: community understanding and support of MOUD. That's been the case. I think it's less so than it was a decade ago when I first got there, but certainly when we talk about stigma, potential solutions, sequential intercept model mapping was one that we brought forth, engage community in learning opportunities and provide training to staff, because it's not just about community, it's also staff of all kinds of agencies, really. And the challenge, the logistics of MOUD continuation of induction. It can be complicated, and we worked on some complications with and in the system. And potential solutions utilizing interdisciplinary team and consulting with technical assistance providers, and starting with a pilot program, which is what we're looking at in Brunswick County. So the goal of completing the SIM mapping, which is what we're looking at doing as a part of this process, would be to gather all county stakeholders and create a strong interdisciplinary team that addresses the needs of those involved with the criminal justice system, both participants and staff, leading to comfortability in providing feedback during both the planning and implementation process. Community engagement, table events like the Mental Health Summit, commission meetings within schools, churches, fundraisers, etc., and provide education and personal experiences with addiction treatment. As far as staff training, that would include training for detention center staff, medical providers, psychiatric providers, behavioral health providers, basically all staff that would be engaged with MOUD in the detention center. Training would include topics like addiction and recovery, MOUD science, stigma, trauma-informed practices, diversion monitoring, and best practices with MOUD in the detention setting. Ensure each voice is heard and able to be influential as part of the planning process to create a feasible and effective program. Technical assistance providers like Vital Strategies, which were great for us, Rulo Strategies, and NCTAC have been beneficial to discuss with other detention centers with their MOUD programs. We've really learned a lot as a part of this process. And we've connected 3 other counties as a part of this, kind of just to hear what they're doing, what's successful there. A pilot program allows us to try things out and figure out methods that could work within Brunswick County Detention Center specifically. So that's part of what we're doing. Okay, thank you. Let's talk about our team. This is our team really enjoyed learning about what other counties have in place already. Has been extremely interested in the SIM mapping, and our second session was unique. That let me just speak to that. Our second session actually in the Brunswick County Sheriff's Office, and we had consultants, and we ended up at the end of that time getting to meet with the sheriff in the sheriff's office, which was really great. I'd never been in the sheriff's office before, 10 years in Brunswick, and never been in the sheriff's office. I didn't know if there was anything past the lobby, honestly. And the fact that we got to do that in this small environment and work with our coaches was just tremendous. By the end of that time, we had just gotten into this small room and done so very much celebrating progress and looking ahead. We got to meet with leadership, as I just mentioned. The meeting went well. When again, years ago, just even 5 years ago, the idea of MOUD in the jails in Brunswick was a non-starter. And the fact that we got even to this meeting was wonderful. In conclusion, thank you so much. Whoever has begun this process for this academy, we are so grateful. We're so thankful for this academy and what it has done for Brunswick County and what it has done for us, bringing us together, these solutions. Our coaches were so wonderful, and I can't thank you enough for that. Thank you. No.
Good morning. It's still morning, right? Yep. I'm Virginia Fagg. I am the opioid settlement project manager for Cabarrus County. And thank y'all for having us. Thank you for whoever's in charge of saying we needed to have this academy, because it has been such a gift. And it's just, we've learned so much and we have so much support. Like he was just saying, our OSET team they're my friends now, like real friends. And I'm like, yeah, okay, this is real. We spend a lot of time together. So, yeah, okay. So, I don't know do I have a clicker? Oh, listen, I'm sorry, guys. There we go. Oh, I can't see that, that's for sure. Okay, so, a little bit about Cabarrus County, if you don't know where it is. We are Concord, Kannapolis, Harrisburg, Midland, and Mount Pleasant. It's like we have the high octane NASCAR. And then also the Avett brothers, all of the racing families, Cannon Mills and North Carolina Research Campus. I was raised in Cabarrus County. I was born in Mecklenburg, but I was raised in Cabarrus County, and I can honestly say it has been such a gift to be back. I'm so proud of where I'm from, and I'm also, it is not lost on me that we are not all fortunate to say that. So it has been a great 5 years since I've been working in Cabarrus County, and anyway, we are wealthy in resources, and I think this academy has really helped us see how to sort of pull those together and get everyone connected with this. I'm gonna kind of skip over some of this because everyone else has already explained to you, but we do have a medication-assisted treatment program in the jail already. And so that part has already been done, and that's funded through 11 and 2, sort of as like a joint strategy. We also have an MAT program at Cabarrus Health Alliance. And Cabarrus Health Alliance is our health department, our county health department. And as well as we have 2 community paramedics that are funded through the EMS program, and they are able to go out to the community. So this is sort of like the beginning. We kind of have like a little bit already in place as far as this like reentry, just simply because if there's a gap in services, if someone needs, like if they're being released from jail, then the community paramedics can go to where they are and help them for up to a week or 2. So let's see. Our team was myself, along with Kristen Klingelsmith, who is sitting right there. Thank you for being here, Kristen. Kara Clark, who's the Deputy Chief of EMS, and Dr. Camila McKissick, who's the Director of Behavioral Health for Cabarrus County, along with Lieutenant Matt Fisher and Captain Wallace, both from the Sheriff's Department, and Sonia Bohannon Thacker, who is the Director of Behavioral Health for Cabarrus Health Alliance. So we, just like most counties in North Carolina, were heavily impacted in a negative way by the opioid epidemic. And so I was blessed because my supervisor, Dr. Elise Pugh, had, before I was in this role, she got so many things already in place and the ball's rolling. And so this last year and a half has really just been about like managing, figuring out like, okay, now we have so many programs. What are we lacking, and how do we connect, like make that connection with all of them? Again, we did complete our collaborative strategic plan in 2024. So we'll be doing that again in 2020. It will have to be done by 2028. So we'll be starting that beginning of this fiscal year. And so like I said, we currently have Strategy 11 funded for the addiction treatment in the jail, but this academy, I guess our purpose for this was really to focus in on the reentry program and creating and facilitating conversations in the county to make sure that people are getting all of the resources and programs that they need. Let's see. So our hopes, we hope to restore hope, dignity and opportunity by empowering individuals to rebuild their lives after incarceration, creating safer communities through second chances and shared accountability. We want to make sure everyone leaves when they're being released from jail. And this, obviously with opioid settlement funds, that's our primary focus. But in general, when they're being released from jail, anyone, whether they are being released with an OUD or not, but that they all have some level of a personalized plan and hope that they can follow it and commitment that they can follow it. We want to build and encourage those community partnerships to create pathways for employment, housing, and mentorship. That's one thing we really looked at during this academy was, what are the barriers that people experience? And then how really can we mitigate those? And I think we've identified as a county in the past, and it will probably continue to be true until we can really invest more time and energy into it, but the housing, affordable housing is definitely an issue. And so that's going to be a big focus for us. Now that's going to take time, but I think I know we're all committed to that, and we all see how just important it is. And we have a lot of land in Cabarrus County. The Cabarrus County is it's interesting because we're both rural and a little urban and very suburban. So we're a suburb of Charlotte. So, but we do have a lot of land. And so I think that's been a big focus for us as far as maybe trying to figure out something for housing in that space. And again, what are the barriers for employment if you're released from jail? If this is your third time that you've been to jail, but they're nonviolent, charges, well then who can we partner with for employment and or education so that they can, potentially get something that might not keep them in a cycle. Bless you. And then obviously our annual report will highlight the outcomes and our success stories. So as far as challenges, this will be the first time that I do an RFP ever. So I went ahead and put that up there, even though I do think that with the team that we have, it's very pretty diverse. I mean, we're all like in the field, but having that support already in place, it means so much. That's one of the things about this academy is everyone took days of their time to sit here and be committed. And like that to me is huge. Like it's hard to get people in the same room for 1 hour, but you're talking about 2 days, 3 times. So, I mean, yeah, it's been, I feel like we can see the commitment that we all have. And then we also have to do an RFP for our collaborative strategic plan, which will ultimately support these efforts as well. So those are the upcoming things. But just making sure that we are focused on harm reduction and trauma-informed care principles, stay the course of evidence-based treatments, and just making sure that we have that collaboration and transparency for our community, as well as like we work a lot with Mecklenburg and Iredell and Rowan. So just, I think that's also been part of the camaraderie that this academy has helped create. I think as a group, we were just really impressed with, again, like I said, the commitment that everyone made to being here. It was October, February, and then now, and I mean, it was reassuring. Like I said, the OSTAT team is always fantastic, but just like, again, that people showed up. And as far as, getting an actual plan in place makes life so much easier than when you're just trying to, like I said, reach out, not getting emails back, not getting things. And so then now we have a core group of people, a core group of people to really help propel that plan for us. So here's some cute pictures of our mapping. We have some OCD people in our group, yay. So it was very, very organized. But as far as looking ahead, we are working on, again, like the RFP, developing our SOPs just for our county, and getting that in alignment with OSTAT. So Cabarrus County plus OSTAT has to merge, and for good reason, there's a lot of stipulations in both. So that's been a fun challenge that I'm basically a part-time accountant and part-time attorney these days, okay? And also always a therapist and always need that therapy. But really just focusing on our long-term planning and emphasizing sustainability, because these dollars aren't going to be here forever. And so just making sure that we are putting those pillars in place, and we have a really strong foundation for this reentry council that we want to be able to grow. But then again, the money's not going to be there forever. So making sure we do have that long-term, and just the collaborative decision-making where everybody's working together, same team, and making sure we are really thinking comprehensively of things that people might need and not letting things slip through the cracks, because we think big, like housing, healthcare and things like that, but there's small things, day-to-day things that I think are really important that really do create hope, or they can destroy. And so like making sure that we are there for our community and the individuals that we're serving, I think is very important. So that's all for me. Thank you all. Marcus?
Good morning. I am Marcus Boyd. I am the opioid settlement program manager for Mecklenburg County. Representing Mecklenburg County today, along with James Searcy, who's a certified front-end reentry specialist for Mecklenburg County. We're proud to talk about the work that we've done with the Opioid Settlement Academy and with the support of OSTAT. Today, I'm going to walk us through how we're strengthening our justice-involved strategies to reduce overdose and improve continuity of care in our community. So just to level set, give you some information about Mecklenburg County. We're one of the fastest growing counties in the country with over 1.2 million residents and growing daily. The last estimate was that there was an additional 157 people added per day. Our work has become guided by our new county manager's vision of one MEC, a recently coined term, which means a unified resident-centered approach to delivering equitable outcomes across systems. The spirit of coordination is part of our identity. MEC Day, or the Mecklenburg Declaration of Independence, reflects a tradition that Mecklenburg residents declared independence in 1775, prompting General Cornwallis to call the area a hornet's nest, which is a term we've near and dear to us. We've had a minor league baseball team called the Hornets, and we also have the Charlotte Hornets of the NBA. That still applies today because addressing overdose requires the same kind of coordinated cross-system response. Our detention center is the largest pretrial facility in the Carolinas, places us directly at the center of the issue. From 2020 to 2024, overdose deaths averaged about 24 per 100,000, peaking near 30 in 2023, with disproportionate impact on African American and Hispanic residents. So when we talk about building a coordinated reentry system, that's one MEC in action. Our academy team. The work is only possible because of strong cross-system collaboration. This team is a mix of essential components, including detention leadership, public health, clinical expertise, and community-based reentry support. That mix is essential because reducing overdose among justice involved individuals requires coordination across multiple systems. Again, I've mentioned his name once before, but having someone of Mr. Searcy's expertise with reentry and peer support was essential to this team because he gave us insight into how we wanted to develop our programs. So we chose to focus on strategy 12, which is reentry. To level set, we recently started our first post-overdose response team, and our Mecklenburg County launched its first full-scale medication-assisted treatment program inside the detention center using opioid settlement funds in 2025. It was a major step forward for us, but we identified one of the critical gaps that needed to be addressed essentially quickly. And we know this, the moment of release from custody is one of the highest risk periods for overdose. Without continuity, people leave a controlled environment, often with reduced tolerance and face immediate risk. Our reentry strategy is designed to close that gap, building a true bridge from detention to community care so people can stay connected, supported, and alive. Our goal in our county is to reduce fragmentation at the exact moment people are most vulnerable. We're building a coordinated system that connects individuals leaving custody to treatment and recovery support, harm reduction services, primary care, housing, and employment resources. With some intention, I will note that our community has invested in 11 of the 12 strategies that we are tasked with Exhibit A. So that's not out of just wanting to do it to say that we've done it on papers because our community needed those services and we were able to invest with some of our community partners. When we talk about a vendor network, we mean that structured group of providers, treatment agencies, outreach teams, support services working together with shared expectations and coordinated communications and less silos. For example, someone starting MAT in detention will leave with a scheduled appointment, a direct connection to provider, and follow-up outreach, hopefully within the first 24 to 48 hours. That level of connection and coordination is what drive outcomes for us. We expect to see stronger engagement, earlier intervention, and ultimately a reduction in overdose incidents in our community. Challenges and solutions. The work is complex and we've been intentional about naming our challenges. We have a lot of eyes on this project, and that means we have a lot of opinions about this project, and we have a lot of folks that can hold us accountable for the work that we do, and that's exactly what we want. We want to be able to identify the needs in our community and move forward with precision. Coordination across multiple systems can be slow and inconsistent. Our response has been building a structured vendor network with clear roles, shared data practices, and regular communication. That's including at our mandated quarterly meetings, but also just building an inner network of communication where the vendors have access to each other at a continuous basis. We just had a vendor meeting on yesterday, as a matter of fact. Second, reaching individuals before a crisis occurs is difficult due to stigma, access barriers, and system fragmentation. To address this, we are expanding outreach capacity using evidence-based engagement strategies and creating smoother referral pathways so support happens earlier. That includes building MOAs, data sharing projects to ensure that a person can get connected when they need to. We've already started strengthening those connections through some cross-systems meetings, bringing partners together. As I spoke about earlier, we had a meeting yesterday with our vendors. We also had a large gathering at our Stancil Center in November 2025. The Academy experience, this is our second time coming through the Academy. I'd say we did it the first time. We didn't know what to expect, but that program or that Academy helped us launch our post-overdose response team. We felt so strongly about it that we probably were at the front of the line in doing the application the second time because we knew we wanted to build a supporting program. It gave us something that we did not have previously, was time to slow down, as Ms. Fagg spoke about. It was space to slow down, align. It helped us clarify what we were trying to change and how all the pieces connect. And hearing from other communities reinforced that this work is challenging. And I was talking to Yadkin County earlier, and I've heard from Brunswick County just recently. We were able to get that information, work across lines with Cabarrus, and we've even built a regional collaborative that we really get a lot of great information out of and determine how we want to move forward the best way possible for our community, but also understanding that we must help our neighbors as well. Progress. One of our key early wins has been defining our reentry model. We looked at the currently funded programs and we determined what we needed, but we also spoke to our community and asked, hey, what's missing? Oh, when a person comes out of detention center, you have MAT now that's at a full treatment level. What happens to that person when the door is shut and they're leaving that facility? So we know we needed to then create a program as a warm handoff, a footprints in the sand per se. One of those key things is, so we paired it in what we're doing now, my apologies. One of our key other ones didn't define the reentry model, but what the plan is to pair an internal detention-based center role with an external community-based center role, both under the reentry strategy. When we build the strategy, it's going to take the place of the post-overdose response team who has been temporarily filling that gap in for our detention center. Now we're moving from planning to implementation by actually getting the available quotes and starting to work to bring this into fruition, hopefully by the beginning of fiscal year 27. Ultimately, this work is about one thing, and that's what we've defined in our community and across the state. It's about making sure people survive the most dangerous moment in their recovery journey, giving them a real chance at stability when they return to the community, so we all put our best foot forward. Thank you.
It is fancy. Good morning. My name is Savannah Hayes, and I am the Opioid Prevention Coordinator for Stokes County. That's for the first one. I hold a bachelor's in nursing, and this work is deeply important to me. I'm going to attempt to condense more than 28 hours of collaboration, which is about how long we were all together, and we still like each other, into about 8 to 10 minutes. So you guys bear with me. This is not even close to all of the work that we did. Today, I will be sharing our county's experience with the North Carolina Opioid Settlement Academy, including what we set out to do, the challenges we faced, and the progress we're proud of. One of our team members is attending a college event this weekend, but she may be watching online, so everybody say hey to Crystal if she's online. We also just added a new peer support specialist that may be watching online, and her name is Tina. I do want to say before I get into this that Nidhi, you said there were 2,600 requests for technical assistance. I feel like we were maybe a third of those in Stokes County. We're on a first name basis. So this is a little bit about Stokes County. I want you guys to kind of have an idea of how rural and tiny we are up there in the top of the state. The city that we're currently sitting in has 471,000 people in it. That's just the city. It's not the town. It's not all of its boroughs. It's just Raleigh. In Stokes County, we have 44,900 people in the entire county. So just for scope, we're very, very small. Our median age is about 47.6. That's older than the state average. And our largest municipality is King. Has anyone in this room even heard of King? A few. Okay, there's 7,000 people in King. So we're tiny, but we are mighty. We are trying to do as much as we can to reduce this overdose rate. I'd like for you guys to look at the overdose death rate in Stokes County, and that's specific to deaths. Initially in 2022, we saw 53.2 deaths per 100,000 residents. That climbed a little bit in 2023, and our team was created in 2024. Now, I can't say that that lower number is 100% because of our team, but I can say that we had a large part in it. We started with a community paramedic. I'm actually going to go to the next slide so I have pictures to show you guys because they're my favorite people. All right, so our community paramedic, Crystal, she is here with us today. She is sitting right in front of us. If everybody can give her a round of applause. She was our first, I guess, person in any of the opioid response, anything like that. She was the first funding that we spent. And her work has been invaluable to our community. She started the work. I came next. That's me on the left. I am the coordinator. I'm basically here to support these guys and make sure that they can do their jobs. Crystal is the one that's in Maryland. She's our certified peer support specialist. She was our second hire because we knew that we needed that lived experience and that, voice within our community. She has been invaluable. Like, I'm not going to go into it too much because I always get emotional about her. She's invaluable. And then Anna, I'm sorry, you don't make me cry. She's our accountability and recovery court coordinator. She actually joined in November of 2024, and the four of us have spent a lot of time together between the Opioid Settlement Academy and all of the work that we do within the community. We have a lot of group chats, I'm going to try to speed up a little bit. I know that I'm talking too much. So I'm really excited about this first venture into reentry services in Stokes County. Our jail typically has about 68 bed capacity. So this is a small county, this is a small jail. And so the work that we're trying to bring in is, it's going to be impactful. Our initiative is centered on reentry services for justice-involved individuals with opioid use disorder. Currently, we do use funding to fund our accountability and recovery court coordinator position under recovery support services. So we do not actually have a justice-involved initiative funded yet. This would be our first one. Stokes County is a high-need, low-resource environment. We experience geographic and systemic isolation. Things like transportation are so important. Has anybody been to Hanging Rock? In Stokes County, yeah. So if you've been to Hanging Rock, imagine that you were set out at Hanging Rock and you had to figure out where you needed to go. Like, there's no street lights, there's no sidewalks, you are literally in the middle of nowhere. And that's pretty much where our jail is. So a lot of times people come out of our jail and they say, we don't even know where we are. Like, what town are we in? Where are we? So that reentry part is going to be vital for success in our county. These are our hopes. And at the heart of our work is a mission statement. The Stokes County Reentry Initiative exists to help justice-involved individuals affected by opioid use return to the community with dignity. It's a big one. Stability and consistent recovery support. And this is to strengthen the health of Stokes County overall. We hope to increase connection to services by offering in-person classes within the jail. This is our first venture into, number one, interacting with the jail, and number two, with having any sort of support services within our jail. Right now we do continuation of MOUD, so we're trying to get some support classes in so that we can maybe make those connections. So some of the challenges and solutions, we do a lot of the work ourselves. So a lot of our actual SCOPE members, our program is called SCOPE, I didn't say it in the beginning, but a lot of our SCOPE members actually have gone to class to become facilitators for some of these classes that we hope to bring into the jails. So that we're not walking up to, someone at the jail and saying, hey, we think you should do this. We can come to the jail and say, hey, we can do this. Will you let us? And that gap is already taken up. We're able to kind of work a little bit ahead of the curve. That's us. That's my team. That was on session 1 in this room. And that was our strategy map at the end of session 2. We worked so well together, but there were so many Post-it notes. They were falling all over the place. I'm not even sure what that stack is. Maybe it made it onto the board. I don't know. It was so much fun to be able to collaborate. And y'all want to read this? I put it in here just so that you can see the amount of work that we did during this. Every single thing here is a thought that someone had. It is a consideration that someone had. It is a partner that we potentially can look at after we leave. It's all connections. And even in a town as tiny, or a county as tiny as Stokes County, we still have these resources available to us. Our experience was that we were given freedom to collaborate. So a lot of times when you guys come to something like this is a lot of what you're doing. You're sitting here, you're listening to someone speak. It's educational, it's interesting, but very rarely does anyone say, you know, go talk to your neighbor, or go over to this table, give you time to work. So that was probably our most important part of, I'm not even on the page that we're doing. Sorry. That was probably the most important part of the academy, was for us to be able to sit down and, you know, the OSTAT team would go up to the front and they'd be like, okay, go work. And you'd have hours, not like 15 minutes. You had hours to be able to work on this stuff. And that's how that strategy map was formed. Okay, so this kind of goes a little bit more into detail about what we have done. We've added our second peer support specialist literally 2 weeks ago. She's going to be supporting our MAT program within the health department. We are so excited about her. But that will open up our initial peer support specialist, Crystal, the one that was here with us, to be able to help with some of these classes that we're talking about getting into the jail. She is already Smart Recovery Facilitator trained. Anna is Smart Recovery Facilitator trained. I'm sure I'll find something for me and Crystal to get trained in. And hopefully we'll be able to actually offer the classes ourselves, because we're bringing the expertise into the jail. And I didn't realize it was going to end there, so thank you, guys. Junior. I'm going to turn it over to Junior.
Just click anywhere. Good morning. Happy Friday, everybody. Good to be here today. Good to be back in Raleigh. Just want to thank y'all for hosting this and having us and being able to come together and collaborate. My name is Junior Thompson. I'm the pretrial release coordinator for Yadkin County. I've been doing that in Yadkin County for the last 14 years. I worked with Piedmont Triad Regional Council prior. I just have switched over to the county. Been with the county for the last 2 years. When we got into this strategy of justice involvement, that was a good thing for us to get in and brought me on board. But there we go. Yadkin County, our motto is come for a visit, stay for a lifetime. And you want to talk about small. We are small. We just got a tractor supply last year. Until they put that tractor supply in, we had to leave the county to buy shoes. There's no Walmart, there's nothing in Yadkin County, and that's the way they want it. So, but we are small. A little bit about Yadkin County, we have 37,722 people as of 2025. Our overdose death rate as of 2024 was 23.7 out of 100,000 residents. That represents 9 people who died of an overdose, and this is a decrease of 57% from the prior year. Our detention center in Yadkin County currently has a capacity of 100 people. The jail list I went through yesterday, that average length of stay was up to 124 days. So you've got those folks that are there for a while. Our team that we put together, I'll flip to the next one that puts a face with a name. To the far right is Carolyn Pearson. She's a corporal with a detention center. We wanted her to be a part of our team. We felt she would be valuable with her knowledge of the day-to-day operations of the detention center for us putting together a plan for some type of reentry. Of course, myself. Next to me there is Lakin Royal. She's the Assistant Director of Health and Human Services in Yadkin County. We wanted her to be a part of the team with all the resources that Health and Human Services bring. Then, of course, we got Marie Walter, she's our opioid action coordinator. She's with me here today. Marie is the hub of the wheel, and all of us are just spokes that connect. She keeps us all together and keeps us all in line, and that is our team. So why reentry? Strategy 12. We looked at reentry. Again, our detention center has a 100-bed capacity. They're actually looking at expanding that, doubling the size, because we currently house folks for Halifax, Vance, Allegheny. There's like 2 other counties. We've got some from Forsyth and some from Davie. So we house inmates from other counties. But out of that jail list that I go through every day, again, this says 50%. Yesterday, it was 53% of pretrial detainees had drug-related charges. 53% of the folks in jail. You compare that to 13.5% that are charged with violent offenses, 13% are charged with property-related offenses, 6.7% are charged with sex offender-related offenses. And that 53%, those are folks that are just charged with drug-related offenses. Now, the violent offenses and the property offenses, a lot of those probably occurred because of a substance abuse or opioid use disorder. But on average, you've got 50% of the individuals that are housed in the detention center have some form of OUD or SUD. And again, they're there an average of 117 to 124 days. Our hopes for Yadkin County is through collaboration with local agencies, faith-based organizations. I also pastor a church. I'm bivocational. I pastor a church there in Yadkinville, to get connected with those faith-based organizations, employers. Yadkin County is committed to fostering second chances, restoring dignity, and empowering every individual to build a productive, purpose-driven life. We hope to use reentry to meet the needs of those in the detention center, so that when they're released, they'll have those resources, they'll be readily available. We hope people leaving the detention center will be supported and connected to care in ways that celebrate the goodness and positive impact that they can make in the community. Challenges and solutions. Overall, the biggest challenge we face is lack of support and buy-in, just from partners and participants. That would be our greatest challenge. And I think the hardest thing that any of us can do, and I know from being with this opioid academy, whether it's Yadkin County with 100 beds or I think Mecklenburg, they said their jail, they had 1,842 inmates it was. Our biggest hurdle is to build a bridge over that stigma. That stigma is such a thing. And it's getting folks to buy in just to reach out and help those people. But we plan to overcome this just by approaching our partners and participants with just open communication and letting them engage in this vision at their discretion. What are they comfortable with? But let's do something. Let's get together and do something. Our experience at the academy, it was a wonderful experience. The coaches, you guys are awesome. There they are. You guys are awesome, just to be able to sit and talk. And again, like I said, collaborate with other counties and just see what's going on in other places. We're all rowing the same boat, and it's just the challenges are the same wherever we are. But just to be able to discuss those and come up with plans to be able to present and address those issues. And again, there's our strategic map that we came up with. It was good just to sit down, align all the resources we had, key activities that we needed to do, the immediate results that would come from that, and then the short-term and the long-term outcomes. And again, the hopes of all this is to reduce recidivism, increase community education and awareness, decrease the unemployment rate with connection to opportunity, and just increase the physical and mental health and by connecting those folks to services and reduce the overdose deaths. Is educate, connect, and follow through. Once these folks come out, it's reaching out in 30 days and 60 days and 90 days. Past that, just saying, hey, we're here. Is there anything you need? How's things going? And just let them know, guys, somebody cares. Somebody cares. And we're here for you. and just want to help you. There's me encouraging Marie. It's almost over. And, we did not color code our Post-it notes, and I was so disappointed when we got done and we seen the other tables. Ours wasn't color coded, but, we had a good time. Celebrating progress and looking ahead, the pretrial release coordinator position, which is my position, they just have, authorized that spending resolution. It took me 2 years to get that there. They were talking about budget shortfalls. I said, hey, strategy 10 is my job description. You know, why don't you pay me out of this? That'll free up some money for you. But that's put me and Marie together. We've had some good discussions with our sheriff. Our sheriff is wanting to bring in peer support services. So I'm currently meeting with him, and he's looking at other counties, Surrey County in particular, at some of the things they have set up. And we're just excited to see this vision just come to life through steps that we're taking with our sheriff's office and just being able to provide services to those folks that are just as involved. Because right now, I mean, in Yadkin County, we're doing nothing. So if we do something, it's better than what we're currently doing. But I think that is it. But thank you all very much.
Are you impressed? Because I'm feeling real fuzzy inside, and just really appreciate all the work that our local governments have done through the academy. So if we can just give a big round of applause for all of the academy team members. I don't want to jump to, I forgot to put a little transition slide, so the little teaser, we're gonna get to lead in a little bit, but I don't know how to turn this off, but here we go. Imagine this is for later. We have some time to have some conversation, and so would love to welcome our panelists up to the stage and welcome questions from the audience if you've got any, as well as we've got folks on the Zoom online. So if there are questions that want to come in from folks out in the world, please feel free to put them in the chitty chat, and our dear friend Anna will raise them into this space. But I just wanted to offer room for folks to ask any initial questions if you've got any, and then I've got a couple of my own teed up just in case. But just remember, like, these folks are doing really hard work in their communities. They're starting from scratch in some places with very little resources, but also realizing that they have probably more than they thought, which is pretty cool. And they're connecting dots, and they're bringing really important people together, and they're centering people with lived experience both on their teams and in their communities, and doing the really hard work of making sure people feel supported and, again, keep their dignity as they're transitioning from incarceration. So, any questions from the room or the virtual room? We do have live mics, I think, up and ready.
Yep. Oh, no, I'm coming.
Thanks. Yeah, please.
Hi, I'm Vera Reinstein. I'm a pharmacist with Alliance Health, one of the 4 tailored plans. And I should start off by saying I'm very biased about medications for opioid use disorder. And I guess I did hear Marcus Boyd mentioning MAT continuity, like, and with an external community-based position. And I was curious if how you're funding, I guess, the medication part, because as I talk to people, sometimes that's sort of the black hole. They're just thinking they'll get it somehow or another. And I'd be curious, everybody else as well.
That's great.
Want me to answer first?
Yeah, just for your folks, the little button on the front.
Yeah. You don't have to hold it. That's what I
Oh, cool.
thought.
So as part of the continuum, the reentry position is going to connect to other opioid settlement funded vendors. We have additional OTPs and OBOTs that are funded under the settlement. So we're working with those programs to build a seamless referral process. So we're using that reentry position to connect to those 6 vendors so they can have appointments there as quickly as possible, or reconnect them if they've already have an established provider to their original home. But if they need a new appointment, they'll be able to go right in and get one with one of our funded partners.
So the providers then provide medication if it's OBOT, they actually do the contracting with the pharmacy?
Yes. Yes.
Okay,
So it's really what we have, it's facility-based, no, I'm sorry. It's a FQHC and FQHC lookalike that are the main
Okay.
partners, and then we have 4 OTPs in Mecklenburg County.
okay. I would kind of encourage everybody to think about, I guess, I know this is justice involved, but my dream is always to have sort of like a countywide access point, like
Yes.
not specific things, but I think that's great. Thank you.
That's also part of what we offer in our communities because of your organization. I know Alliance does have some access to MAT medication, so we utilize that service. So thank you all.
I'm just concerned we're trying to keep it up and the funding is not there, so I will talk to Nidhi about how to make
Also,
sure it's
just to
there for the
clarify,
justice involved and everybody.
yeah, happy to help answer questions about it. I also do not touch any of this money. I'm very grateful for that. But yes, happy to chat with you about what's possible. And thanks for putting your dreams in this space too. We're all dreaming. It's good. Any other questions from the room or from online?
We do have a question from online. Doug is asking, is anyone braiding discretionary grants with their OS work? So for instance, SOAR or SUPTER's block grant work.
Thanks. So is anyone braiding opioid settlement funds with other funding sources, whether they're federal or state or either other local dollars too?
So I'm going to say yes. We have the Prevent Drug, Cabarrus Health Alliance has the Prevent Drug Overdose Grant through the state. And we have been able to work with, obviously with CHA very closely, but I would say like that we have a Narcan vending machine at our detention center that's right outside the magistrate's office. So it's available 24/7, 365. And so while that, I don't know if that's really braiding funds, but it's obviously they can buy Narcan with opioid settlement funds, but that vending machine's already there. So we can braid those funds because that's also that grant will end this year. Is that correct, Kristen? Yeah. So I think then we'll be braiding for sure, but being able to maintain that, that service and utilizing what was purchased through the Prevent Drug Overdose Grant.
Anyone have any other thoughts? We know that the opioid settlement dollars are a meaningful amount of money. Yes, we will acknowledge that. But we also know that it's not enough to get us to the place where that vision is of all people being connected to supports and services within a culture of care. And so we've got to make some really hard choices, and local governments are, of course, in a position where they are potentially going to have an even harder funding landscape next year. And so I think they're all being really intentional and creative and thoughtful about how they're pulling in funds to do big work with very little resources. So I don't know if anyone else has other thoughts about how you might have combined other grants or funding sources to do opioid settlement work or opioid-related work.
So we have overdose data action in our community, and the opioid settlement is now technically part of that initiative in that we're housed in the same area. We also utilize some of the OD2A data like Hotspot and to recognize how we allocate our dollars on the opioid settlement side with using some of that data to drive some of the program building. So it's not necessarily braided, but it is working together with those programs. We'll also, the reentry program will be modeling what COSUP does within our detention center. So another opportunity to work together in that landscape.
We're very early in the process and haven't accessed anything, but just having communicated with other counties who are much further along than we are, the information we got was don't turn down any opportunity, right?
Mm-hmm.
So I think part of that is keep eyes open, keep possibilities open for funding. So if braiding is part of that, you know, that's a good idea.
Good idea, yeah.
Of course, I have to speak on this one. I will say that as a smaller county, sometimes the challenge is that we do not have enough people to kind of justify the grant funding. So a lot of times if you ever see in these smaller counties that there's like a coalition or there's an initiative, like a task force type thing, that's between Surrey, Stokes, Rockingham. That's because between the three counties, we have enough people to kind of, show results that aren't, three people. And so that's something to consider when people are talking about grant funding in the smaller counties. When you collaborate, you really can get access to those federal and those bigger dollar funds. But if you don't have that collaboration, sometimes it can be a challenge.
Mhm. I definitely was picking up on that theme in all of your presentations, is that you all are so proud, and I am too, of the team that the teams you've been able to pull together. And just marveling at how each team has such a different mix of specialization and specialties and different experiences. And I think that's what makes your plan so much stronger, because you've been able to pull in those different perspectives. And since program planning and public health and this overdose prevention work is a team sport, I'm curious if you all could talk about just how you were able to pull those sort of right partners at the right time in, and be really intentional about who you were tapping to say, hey, we really all have this sort of shared need of doing this work. Come join in with me. And, having grown friendships, it seems like to have that really focused time together has been really wonderful to watch. But I'm just curious to know how you assembled your Avengers, your team.
Okay, I'll start. Well, I picked my favorite people. Just they really are some of my favorite people though. And that works out really well when everybody gets along and likes each other. That's what, when she said that made me laugh, that we still like each other. I'm like, I think we like each other more now. It's cool. But that, so obviously we needed representation from the detention center because that's going to be kind of our hub space. We got to make sure that whatever we want to do is actually feasible for them. And so having that support, and then the health department, Kristen and Sonia, they have such a great presence in the county, and so many different programs. And that, I feel like I'm like, so still feel like I work at CHA some days. I'm like the biggest advocate for them. But I work at the county now, but that's, they just have so many different programs and resources for people that just don't get tapped into. And so it's really nice to have that representation because of that vast array of opportunities that are there through the health department, as well as, and then Kara Clark, so she's our deputy chief EMS, and she is the supervisor for the community paramedics. So that was kind of an easy decision once we realized just how much they're already doing in the community. So she kind of jokingly said like, well, we're basically the reentry right now. And I'm like, yeah, and that's unfortunate for them, but I mean, it's fortunate for everyone, but unfortunate that it all kind of was falling on them. So really, I think for us, that was did I forget? Oh, Dr. McKissick. She's also behavioral health. So it's just really important. We're in the midst of opening a new behavioral health center in Cabarrus County. So having all of those perspectives and vantage points, I think, was really important for us.
Mhm.
With us, the idea to pursue reentry came after the identification of the gaps. So we knew we needed to lean into bringing in a team or a leadership team that included those that had access to data, like our overdose data action team, and then also our Mecklenburg County Sheriff's Office staff who were over the programs that were within the detention center. That was Evelyn McGill and Dorian Johnson. Dorian Johnson is the director. And then we also needed a subject matter expert that worked within the detention center. And Mr. Searcy is that person, a subject matter expert on reentry and peer support, who does work not only in Mecklenburg, but across the state. Matter of fact, he's about to go do more work after we leave here. But, and then we had Dr. Strzelecki, who has a history of working with forensic evaluations and diversion within Mecklenburg County. It was just a natural fit for all of these folks who had a common mission to make sure that the people that are leaving our detention center ended up in a better space, came together to create yet another tool to help this population. When we look back at it, we probably should have added one additional member to that team, but that's something we'll be going forward. We'll make sure that person's involved in our quarterly or monthly meetings that we develop as part of this project.
Very cool.
Yeah, I would like to say that, I focus on front-end reentry. And fortunately, I have the opportunity to provide front-end reentry, at the Mecklenburg County Detention Center, FCI Butner, and other places. Front-end reentry is at the beginning, When a person is first placed in a pod in the detention center or on their way to prison, speaking to them about their mental health, substance abuse, and all those things on the front end, and so that they will have something to think about as they're going through the incarceration process.
And that's why we decided to work really on motivational interviewing as a tool, really from Mr. Searcy's input. Like, we knew we had to get the people who not only were part of the MAT program, but the ones who qualified for it but didn't take part in it. To utilize some of the MI and some of those stages of change work that he utilized as front-end reentry as part of this program. So really the model that we're following is with the work that he initiated.
So my experience was very different than Cabarrus. I didn't know anybody on our team except Emma, who was our team lead. And you were there our final meeting, and you know the growth of that team. By the final day of that meeting, our team was hugging each other. And by the way, I'm a moderately neurodivergent man. And so I was like, hugs. Oh. Okay, fine. Hugs, okay, fine. But the team experience was so good for us in just developing through what we needed to do. And I will say, also the second point I will make is in legitimizing what we did, bringing Vital Strategies in, really legitimize what we were doing, and bringing you guys to the county. I know that wasn't the original plan, but really legitimize what we were doing to those parties that we really needed on board. And that was huge.
So as my counterpart, Junior Thompson, said, that he is our pretrial release coordinator, and he's an invaluable member for our team in Yadkin County. His experience is a testament to the services he provides to the members of Yadkin County itself. So there was no contest in selecting him as a member of our team. And then Corporal Pearson, Carolyn Pearson, she works in our detention center. So she comes with this wonderful knowledge of the individuals who are inside of the detention center at any given time. So she was a great representative to select for our team as well, because she and Junior have a great rapport with each other. He sees her on a pretty regular basis when he goes down there to talk to individuals who are housed inside of our detention center. And she also has a rapport with individuals who are currently housed in the detention center. So she is somebody she's a wonderful representative for the county and the community. And so again, there was no contest, no question about it. And as for Lakin, she is our assistant director for public health. And her knowledge is a testament to public health services that are accessible in the county. So should we have a question, she is somebody that we can go to. And if she doesn't have an answer, she'll chase down that answer and get it back to us. And so I think that all of these individuals are a great representative for just kind of the wide scale of services that we currently have access to, and then the services we would love to have access to and be able to offer to the people that we represent. So that's why we selected each one of us. Thank you.
I don't know why my chair did that. I'm sorry. So in Stokes, I was sitting here thinking while you guys were talking, warm handoffs are such a big part of our community, because if you do not get your person, your client participant to the next person, they may not make it there. They may end up in a holler. So for our team, I really wanted to make sure that we had all of those touch points. I work in the health department. I'm a nurse, but I'm also the opioid prevention coordinator. So I kind of, herd everyone into a shared goal. Crystal Wilfong is our community paramedic. So she's actually out on the street. She's doing the home visits. She's with these patients in their environment. So she knows what they need where they live. Anna is justice involved. She's our accountability and recovery court coordinator. So we've got our justice involved individuals, and a lot of these people are the same people, let's be honest. But we love all of them. And Crystal is our lived experience. She can actually connect with, people within our county. So I feel like bringing that team together with a lot of people that care a lot about our community, and the people in it, it just works.
Yeah, I really appreciate you all sort of telling your origin story about how you sort of pulled the team together. And I'm grateful that they're either now your favorite people that you're willing and wanting to hug, or may have started that way. And I think what I'm also hearing is that there's just such a diversity of roles and people who have, again, those entry points into different parts of the community that make this work so strong. And I hope that the people out in the audience and the folks online here, like if you are at all interested in supporting your communities and helping them be healthier and safer, there's a place for you in this work. And I hope that you will join us in it and stay with us in it, because we got a lot to do, right? And so no matter your expertise, no matter how trained up or, whatever you've got in your sort of professional repertoire, as well as your personal experience, there is a place for you to do work with justice involved folks. And we need you to be here with us. So thank you for that. And then another theme that I'm hearing, of course, is centering lived experience, both in the work as well as on your team. And I also get choked up every time I sort of think about folks. And so I invite you to join me in those tears of just appreciation if you want, whatever you need. But I'm wondering if you all can just speak to that. That was a theme throughout the academy of just trusting and listening to the people that are living it. And I'm wondering if you all could speak a little bit to that, of how you've so purposefully, intentionally been listening and welcoming and inviting folks into this work with you that have lived it and are living it.
So it's been very important for us, and that's one of the reasons we made sure that there was a spot essentially allocated on our team for someone with lived experience, but also we get general community feedback. We have a 24/7 survey that anyone can give experiences or just ideas about opioid settlement. We make sure to include a lot of the social media campaigns, just opportunities to provide feedback about how the opioid settlement is going and what your thoughts and visions are, and also prioritizing the engagement from those with lived experience to ensure their voices are not only heard, but amplified.
Mm-hmm.
I was going to answer this one, didn't you? Yeah. So I think that not only does it make the work more rewarding to be able to sit across the table from and my peer support would say this if she were here, I can assure you, she said it in public before, for her to be able to sit across the table from the judge that actually sent her to the prison in Raleigh, and work with her to make a better path for future people that are in the same position that she was in at that point. And she will tell anyone that she needed it. She needed it in that moment, but it's not always the answer. And to have someone with lived experience that can sit there and say, have we thought about this, or have we tried this? What do you guys think about this? And their voice to be as important as anyone else's in the room. That is the most rewarding part of it, that she can speak up, or anyone with lived experience in this room or any other room can speak up and say, this is what I think. And everyone listens, because we've learned at this point, it works. Whatever they say is what we need.
Can I add to that? Lived experience. I'm a person with lived experience. 17 years in federal prison. And during that time, I witnessed people coming back And most of the time it was like for drugs. And when I sat down, and my organization is called Listening First. And when I sat down and listened to people, I learned that we leave prison unprepared. And also, I learned that there's so many resources in prison that we can capitalize on rather than just sit there and watch TV and smoke cigarettes for 20 years. And so, coming out, I realized that, and again, go back to front end reentry, I realized the need to go back in and speak to the people who were just watching TV and playing basketball. And I use the term the 8 dimensions of wellness. We have to do that during our time during incarceration, because if you wait the 18 months, 10 months before a person is going to be released, they already have their mind made up. That's why it's so important that it starts at the front end.
Thank you. Any other thoughts? Check in with the audience as well as online. How are we doing?
Everything he just said.
Everything he just said, big star next to it. Yes, please. Oh, we do have a question. Oh, wait.
Hi, and you may have answered this question with your previous answer, but given your experience within this process, what approaches or messages have you found the most effective for building support and gaining buy-in?
I think you find your people, and for us, it's for me personally in life, find your people and build those connections. If there's one word that would probably summarize my life mission, it's connections, and lean in, right? So figure out what they do and how they do it and how they work. Lean into that support, build on that. And I think that's when you find someone who believes in your mission and what you want to do, cling to them because there is power in numbers, And so I think that's for me personally, and like in this space too, it's like looking at who are decision makers and who are the people that can genuinely provide insight for best practice of how to do things, and bring everybody together and connect everybody, and everybody can be friends and build this great program. So
Connecting people, ideas, good work. Yeah, gotta keep the good ones close.
So, try not to ruffle too many feathers would be my advice. I mean, sometimes in the smaller counties, you're just like, hey, can I do this? And the first person that says yes, you're like, okay, I'm doing it. We'll deal with the consequences later. No, we do go about things the correct way. But sometimes you have to do it a little bit quietly and let that work speak for itself eventually. Because if you're coming to people with data and you're saying, this is why we need it, it may just not translate. They just need to see the work. So sometimes you have to do it without the resources and show that it's needed.
Mhm. Wise words.
yeah, I would speak to, okay, sorry. Sometimes we do it quietly. I know years ago when we got the vending machine at the detention center, at Cabarrus Health Alliance, they asked, do we want to do now it's on, well, I don't know who's on this. If we wanted to do a press release, because this was a big deal, right? And I was like, I think maybe we just word of mouth is cool, because I always wanted Captain Wallace to want that vending machine in that space. I never wanted there to be any reason that I would go there and clean it because I was like, I just want it to be a good reflection of all the things shiny about Cabarrus County. And we don't maybe need to advertise it to everyone. I feel like that the people who need to know, that word will spread. And then that way, maybe there won't be any reason for him not to want it. And till I've just announced it now. But it's been there years, y'all, so we're okay, I think, knock on wood. Okay, so, but you know, I think that that was kind of the way we looked at it was like, let's just let the worksheet speak for itself, and it is utilized. So, yeah.
So I will follow Virginia and Savannah and say sometimes when the work becomes the hardest, when it feels the very toughest, like Virginia said, lean in, because that's when it's about to break and you're about to see something really magnificent happen. And I heard at one of our opioid summits, I can't remember if it was the last one or the very first one, and I can't remember who said it, but it was a very profound statement that has stuck with me, and that it is big ships are slow to turn. And that is one of perhaps the most insightful things I've ever heard. Because in this work that we do, that is so meaningful to so many people who are so underserved and who work so hard every day to be seen and just to get by and live, we provide a very big ship with a lot of things that mean a lot to a lot of people, and it is very slow to turn. So we just have to lean in when it's really hard and keep doing it every day.
I need to record that and be like, my morning alarm clock. Don't give up, lean in. I don't think I was. It might have been other folks in this room for sure, but it's very true. This work can be very hard and slow, but it is very meaningful and will get us on the right course. Do any of you all have small or big advice for anyone else who's trying to start some sort of justice involved reentry, MOD in jails, or diversion deflection program in their community? We've got a lot of folks out there that are probably thinking, this might be something that isn't so scary and I might be able to try it, but need a little bit of a little push. Big or small advice?
Well, as someone who has not yet done it, so is not the expert, I will say that, you know, when we were speaking earlier about, you know, doing classes in the jail and having your own facilitators within your team, making it as easy as possible. Some of the advice that we got when we were speaking to those that work in detention facilities is like, make this easy for me. Like, don't make me add staff. Don't make me add schedules. Don't make me add spaces, you know, fit in to what we already have, because it's so delicately balanced already. And we don't need anybody upset in the apple cart. So if you can fit into that space and make it work for both of you, I think that's the key to success with Justice Involved.
I would like to add to that and say, sometimes you have to work on their schedule and with law enforcement's priorities. So if they're just not ready yet, that's okay. Sometimes it's okay to receive no, and that will kind of lead you to a different pathway, because you can certainly come back and try again and just keep trying and keep trying and keep trying. And it's okay. It's okay to get no, because eventually you can come back and get a maybe, and then you can get yes, because any small step and any small win is still a win. So just keep trying, because law enforcement, they will certainly let you know what it is they need when they're ready. And so take the wins where you can and just keep trying with them.
Thanks for that.
Don't do it on an election year. Oh, I'm sorry. Sorry, are you okay? I'm sorry, I don't know. I don't follow directions, I guess. I would say if you're trying to start something, go to where people in this field are already, rather than trying to like create something that doesn't exist yet. Go find a coalition, a board or something like that that's in our field, and get buy-in from people in the field. I think that's a really good place to start. You're going to get some no's and some naysayers and things, and that's okay, obviously, but you'll get some yeses. And somebody's very likely to say, you know what, I was thinking about that, but I didn't know anybody else was thinking about that. So put yourself in the spaces where you might likely find support. And then you might meet other people through that, with some people that you would have otherwise thought would be a naysayer, but they're not. And so gathering, like, again, power in numbers, and just going to a place where you know people already are likely like-minded. Not necessarily, but you will probably gain some support that way.
And Jeremy, I don't know if you're going to go here, but I just kind of want to tee up like election year and like not opposition, like not opposed to. You can maybe speak to that experience that we had when we were together in Brunswick County.
Just as far as
The presentation we did at the end, how that went.
yeah, so, yeah, I mean, our sheriff did say that, right? Which was,
He's
hey,
not opposed.
I'm not opposed, but I got to win an election first. He said that. Yeah. Let's circle back. Let's circle back. So my comment was going to be, we actually had, this was a different set of meetings, but we had a UNC professor come to Brunswick County to do collective impact with a group of community stakeholders, and said, I want you to imagine mental health, substance use disorder, Brunswick County, and some, just solutions. And we were at the table with some people, everybody had different tables. And I just raised my hand and I said, okay, what's my budget? That was my first question to the professor. And the response was, don't do that. Don't do that. Don't start with that thinking. Okay. So my comment to that is, because a lot of us kind of have that. We do that. We start with limits. Yeah, and I love that you have that kind of dreaming thing that with your presentation, right? I immediately do that. Okay, you give me a number and then I'll give you a plan. And so I think one of the things I'm going to say, because I really had to challenge myself after that and say, all the stuff that we came up with following that was so good because we didn't start with a number, okay? We started with what could we do collectively as this group of people for Brunswick County? And I had to really humble myself over that and say, what is my brain done over this period of time that I'm just going to be like, all right, give me this and then I'll tell you, right? So that's my statement.
I think just a note to say that when we were going through the strategy map exercise, we very intentionally started with the end in mind to try to get us out of this sort of like resource scarcity mindset and say, let's dream into the future of what we want it to be and then work our way backwards to see what we've got to work with. So Mecklenburg County, I don't know if as a two-time Academy attendee also, both of y'all, can speak to that sort of visioning exercise and then how you sort of worked your way backwards and connected dots to programs you had already started, maybe even as inspired by the first Academy. And then we have one more online question and then I'm going to wrap us up. So yeah, so the end in mind, right? Like you have sort of a vision for Mecklenburg County, and because you've been a two-time Academy attendee, you sort of kept this vision in mind the whole time and then sort of pieced programs into it and said, we're headed here, but we're going to do it in all these different ways. You got your port team, you got your MAT in jails, you got now your reentry work, but it's all connected to this vision at the end.
So we knew we needed some of just based on the way that the dollars were allocated as part of the settlement, we knew that we wanted to work with larger programs on the front end, not necessarily throughout, primarily based on, we first started as kind of a crisis response to get the program started, get the dollars in the community, get them working. But we also knew that we needed some very big barriers in our community existed within our facilities. So we know we needed to flesh out how the MAT program worked. We know we needed a response to those who suffered housing instability, also able to dose without regular visits to a clinic. So we knew that when we identified post-overdose response as a strategy on the Exhibit A, we knew that's something we wanted to introduce to our community. And we're still working through that. We have one other larger initiative that we want to create that's going to be able to serve all corners of the community. The programs that we had already started, those were more community-based programs that we knew could provide support to those larger scale initiatives throughout our community. So it really has just been taking what we started as the larger scale initiatives, understanding where the gaps could possibly be, and then supporting them with additional program development to iron out any difficulties.
Yeah, I would add, like Junior said, that what my experience was that, if you do the work, if you just go out there and do the work, the funding will come once people see that the work is positive and it's making results, and the funding will come. And for me, it's not about money. It's not about money. It's about helping people. Not how many people I serve, but how many people did I help.
Just emphasizing those early successes that we had with those programs and building out what the network looked like from there. We knew we needed to kind of have, for lack of a better term, feeder programs to be able to support the programs we've developed. So we can figure out ways to just have a seamless transition through services as much as we possibly could within that network. If you enter any door in the community, you had a way to access care when you left that particular setting. That's whether from home, detention center, hospital, or any other facility. There's a ready-made service that's available for you to connect to, no matter what your source of income is, no matter what area you live in the county. And we're still a model that we're working on, and we're still fleshing it out. But ultimately, that's how we want it to look. It's just a seamless model.
I think you're going to get there. Appreciate the efforts. All right, so was a question online. I just want to.
This question online is specific to Mecklenburg County, and it's just sort of a logistical question. Do you provide a discharge summary for external providers for continuity of care? Sharon is asking the question, and she is the recovery court clinician, and she's worried that a lot of her participants are falling through the cracks.
With the building of the reentry program, it's going to be a voluntary-based program, so it's going to be ROI-based for now. We'd like to have a community-wide data sharing agreement, but we don't at this point. And I'm answering this, I'll say this for the Vital Corps and our remote detention center who actually execute that program. But when a person does come through, the idea is that they be working with the discharge planner initially to get an ROI signed, and that ROI would then be passed off to the reentry person who can then work to get them connected in the community. But because it's voluntary, we don't see any major barriers in getting the ROI signed. What we do need is better coordination of release dates and times, and we're working with our judicial partners now to address that.
Cool. Thanks for the question. Sorry.
And then just one other for everybody, is anyone using apps like Connections for Recovery? Yeah,
Looks like
like
Brunswick.
Brunswick County. Wonderful. Thanks.
Cool. Thank you. Okay, we're juggling virtual spaces that you can't see, and the folks in the room. So thank you so much for going on this journey with me so we could explore a little bit more in depth about sort of how they've pulled together their teams to do this work. And I just delight in the fact that we've got tiny, tiny little places with very tight-knit, close communities who really want the best for their folks, and also really, really big places who want the same thing, also want the best for their communities, and all the work in between. So can we just have a big round of applause again for our Academy teams? This is a big day for them. Congratulations. You've graduated from the Academy. You can throw your cap up. And we'll of course be around for more questions and whatnot and discussion. So I do hope that you'll reach out and talk to your neighbors. But at this point, I welcome you all to go back to your seats. And I would like to invite Lars and Andrea to come up. And they'll be exploring that third strategy, diversion and deflection, number 10 on my dream list. And we'll be speaking a little bit to law enforcement assisted diversion. So thank you, thank you, thank you.
Start. Good afternoon. Oh, it's loud. Good afternoon. My name is Lars Paul. I am the Law Enforcement Program Manager for the North Carolina Harm Reduction Coalition. Thought Nitty was going to introduce me, but that's okay. So my background is I have 30 years of law enforcement experience. I'm a retired captain with the Fayetteville Police Department. During my career, I did basically everything other than truly help people that were using drugs. I did probably almost 1,000 search warrants as a retired as our SWAT commander. So I was on that end, boots on the ground, war on drugs, all that. It's a long story, but eventually towards the end of my career, I was introduced to harm reduction through the North Carolina Harm Reduction Coalition. We worked on some projects together, including naloxone, naloxone for law enforcement back in 2013, and then later on our LEAD program in Cumberland County in 2016. And those were both the first in the state, actually the first in the Southeast to do that. So that was successful. Anyway, that's my background. So between the Marine Corps and this and now harm reduction, my boss is over there. She hired me, and this is actually my third job in my whole life. So anybody else had less than 3 jobs? Cool. All right, so we're going to do just a clicker thing. Okay. All right, we're talking about diversion today. It wasn't why diversion. Diversion is an opportunity for intervention. We're going to go over that. Reasons for implementing a program. I know a lot of the panel was talking about kind of hitting all around diversion programs. The reasons, how programs work, the basics, and adapting programs to your community. And also we'll go over some North Carolina program successes, which Andrea will talk about, and how to get one started. So this is typically about an 8-hour class. If y'all want to stay, who wants the 8-hour class, raise your hand. All right, the what and whys of diversion. What is diversion? It's an alternative to exposure to the legal system, collaboration between justice and community-based services, intensive care management and litigation services. In addition, to address underlying issues that may lead to law enforcement interaction, and it can occur at different points. So basically, in plain English, it's keeping people out of the criminal justice system. Okay, in my experience, and ask any officer in y'all's jurisdictions or sheriffs, it's the same people over and over again for low-level drug offenses or drug-related offenses, sex work, trespassing, fighting, loitering, and they're taking up jail space, and they're not getting any better because we're trying to put, since the war on drugs started, we've been trying to fit that round peg in a square hole, right? That's what we've been doing this whole time, and that's why the traditional things haven't worked. All right, here's some, this is at any of these intercept points is where a good diversion program can work and get people to break out of that cycle. So you have interaction with law enforcement followed by arrest. The arrest can be diverted if you have a good pre-arrest diversion program, such as a LEAD program. If y'all heard of LEAD, LEAD is typically what you think of when you think of pre-arrest diversion. You have initial detention, you have recovery courts, incarceration, reentry, and after returning to the community, sometimes parole. So any of these are all opportunities. Every part of this, if y'all are familiar with SIM, right? That's the big thing now, sequential intercept model. Well, LEAD is a LEAD or a good diversion program that's based on harm reduction principles, is basically a miniature SIM. So we were doing SIM on a micro level before it became popular. And it was always frustrating. We always knew we needed SIM, but now it's finally come to fruition, so. All right. All right. Why do it? Well, like I said before, better outcomes, improve public health and safety, and reduces the strains on officers and detention center resources. All right, so if I'm a police officer and I'm spending an hour of my shift every day dealing with folks that are suffering from substance use disorder, call after call after call after call, right? Or let's say a shift of police officers, have spent a total of 2 hours between, in Fayetteville, it'll be about 13 cops out on the street. They spent 2 hours total time on low-level drug offenses or drug-related offenses. What could you have done with those 2 hours? How could you better use those 2 hours other than bringing somebody to the magistrate, filling out a report, having the magistrate give them an unsecured bond, and letting them back out? You might as well just drive them back to where you got them. That's in many cases. Okay, so that's what we've been dealing with, that revolving door this whole time. How does it improve public health? Well, if you make them better and get them away from chaotic drug use by using a harm reduction approach. I'm not afraid to say harm reduction because it works. I don't care if it's not popular right now, but it is what it is, So if people don't understand it, that's why it's an easy thing to demonize. People don't understand it. So it is what it is. And also, it mentions in the slides, strain on officers. Officers get tired of this stuff. They get tired of the same people, and they're like, what the heck is going on? And they get frustrated, and then compassion fatigue sets in. Even with y'all's where everybody has compassion fatigue, and no matter what discipline you're in, and as we tackle this problem, everybody from every discipline gets compassion fatigue. Even the folks out in Seattle, we work with the National Lead Support Bureau a lot. Some of them will even tell you, they just get burned out, seeing the same thing, and things aren't working because the whole system has to come together to make it work. And this is one of those programs that can do that. All right, the LEAD model. I mentioned the LEAD model. When somebody says that they have a LEAD program, they really have a diversion program that's following the LEAD model. That's what LEAD is, okay? So you can have diversion programs. I know Brunswick is up here. Y'all have the Anchor program, right? Where's Brunswick at? Yes, the Anchor. So that's the diversion program. It doesn't necessarily follow the LEAD model, and it's not called LEAD, but it's still a diversion program. And I respect anybody that's doing anything, any little part of it, like pre-arrest, post-arrest. Anything is better than nothing. Robeson County has the SAFE program, which is very close to following the LEAD model, and we're working with them to bring them more into a harm reduction type approach. But yeah, so there's a lot of counties out there have their hearts in the right place, and they're doing the right thing, and we appreciate that, and we're here to help if you want to bring it to the next level. So LEAD was the very first pre-arrest diversion program. It started in Seattle back in 2010, I believe. They decided in Seattle, they had an open air drug market in an area called Belltown in Seattle, coffee shops, small businesses. And they were tired of open air drug market, people sleeping in the doorways of the businesses, using, IV drug use, syringes everywhere. So what do? What does everybody do? Call the police, right? Are the police going to solve that? Nope. So what happens? They go there and start making arrests. What do police? That's what we do. Cops don't join the police department to become social workers, to deal with homelessness. They're not designed for that, okay? Just because you send them to CIT training for 40 hours, it's not going to matter, okay? They're never going to be good at it. They're not designed for it. So you're going to send a tool, we're sending the wrong tool to fix the problem, okay? So what happened in Seattle is the police go and they start making arrests for low-level drug offenses. 80% of the people they arrest are African-American or other minorities, okay? The population of Seattle is 20% minority and 80% white. So you had a completely lopsided, racial equity issue, I mean. So needless to say, the police department, a bunch of lawyers got together and said, we're going to sue you. And they said, hold on a second, let's all come to the table. Why don't we get together and figure out a solution? Because we're just doing what police do, which is true. You break the law, go to jail. So they decided, look, the police need another tool. They need another tool in the toolbox to fix this problem. So that became LEAD, which also stands for Law Enforcement Assisted Diversion. Okay, so what they could do, how LEAD originally worked, is a pre-arrest diversion program. So if I caught Andrea here with a bundle of heroin, if you can still find heroin these days, it's like a delicacy now, right? Can't find it. So if I catch her and she qualifies for the program based on criteria that my jurisdiction set, I would take her heroin, write a report, do a quick screening form and I'd hand her off to a LEAD caseworker or peer outreach person, ideally. Or I would make it to where the worker would contact her and she can vice versa, right? So basically I make that handoff. So that took me about 30 minutes instead of 2+ hours booking her just so she could get back out, okay? So what I do, this is where you're gonna get pushback when you go back to your jurisdictions, talk to your sheriffs and police chiefs. They're gonna say, that's a get out of jail free card. I hear it all the time, trust me, okay? I've been doing this for years now, okay? That you always hear that, and it's not true. Because if she ghosts me and she does not get with her case manager and do the initial intake, where they sit her down and then, you know, go through what she needs, her needs, and create an individualized treatment plan. That's another key. Once she does that, she's in lead, okay? And I would never bring that charge as an officer, and it goes away, all right? If she doesn't, if she decides, hey, I got them, right? I'm just gonna ghost them, then I can go get a warrant for arrest on that original charge, because I have the evidence, I've done the report and all that, and that is pick her up on a warrant. We've never done that in Cumberland County since 2016, since we started it. I retired in 2020, but I still stay in touch with the program. It's one of my 6 programs that me and my team manage. So, yeah, so that's never happened, but it's there. So it's not a get out of jail free card. So what it does now, and now what happens to the individual is they get linked to services. That's a novel concept, right? Instead of throwing them in jail. So services, you name it, and it depends on, remember I mentioned individual treatment plan? That's the secret sauce behind LEAD or a good diversion program. Because her needs are different than his are different than hers are different than hers, right? For example, go back to Cumberland, you can get a sex worker off the street, put her in LEAD. She wants a place to stay that night, some food, and immediately, this is just an example, this is real people, immediately wants to start working on being able to see her children who were taken away. Right? She's in chaotic drug use. She's, what do I need to do? And, you know, because the caseworker uses a harm reduction approach. He meets her where she is in her life right then. This is what can we do? What would make your life better? How can we improve your life, your quality of life? And it's those simple things, right? For somebody else, it might be something different, totally different. Hey, I need some, we've had crazy stuff. I need some work boots and some new clothes so I can go do a job interview and get a job with this landscaping company. Okay, great. You know, if you let them set the goals, they succeed that way. Instead of telling them, if you don't go to treatment right now, you're going to jail. So that brings us to the next slide. Anyway, case management. Once they're in, they get contacted by their case manager or a peer several times a week to keep them on track and keep them motivated. Okay, I already went over that. LEAD is shorthand for any pre-arrest diversion program. If you go back to your jurisdictions and say, I would tell them I want to start a diversion program. Don't start off with LEAD right away, because they'll Google it and say, oh, this is some kind of left-wing Seattle-based stuff. Yeah. Just giving you advice based on experience. Okay, characteristics of an effective pre-arrest program. Like I said, you don't have to call it LEAD. But to be effective and to be harm reduction based, which is also evidence based, okay? Pre-arrest, you have to have a pre-arrest element. You have to be able and willing to divert people pre-arrest. We have one county. So to do that in Cumberland County, I mean, to do that in North Carolina, you cannot divert a felony, right? Does everybody know that? An officer sees a felony, the officer has to arrest for that by law. You don't have an option. The only way around that is if your district attorney is on your MOU and says, yes, I'm okay with the following felonies being diverted, okay? That's the only way you can do pre-arrest diversion on felonies. We have a county where that happened that we're working with that's just now starting a program. So the workaround for that is start with diverting only misdemeanor charges. An officer has the discretion there. So like, you know, smoking materials, injection supply, paraphernalia, loitering for prostitution, stuff like that, you can divert those at the officer level. So it has to be non-coercive. What does that mean for police? That means if I have you in the back of the police car and I say, hey, you want to go to treatment or do you want to get arrested? I'll go to treatment, right? They'll all want to go to treatment. My buddy, one of my teammates, Greg Berry, who's I have 2 civilians that are on my team and I have 3 law enforcement contractors. So one of my civilian partners on my team, Greg Barry, who's online, he likes to use the example of if you're holding a gun on somebody, they're going to do what you say, right? No matter what. And then the minute you take that gun away, they're going to run, they're going to do whatever they were going to do anyway, right? It's the same thing with coercing somebody into treatment. All right, it's participant driven. Like I said earlier, the participant is going to tell you what they need. You've got to kind of use the crawl, walk around approach with them. And slow, progressive change. We've had people who got into treatment, that was their ultimate goal within a couple months. We've had some in lead for years. They've gotten better. So in my view, and based on the harm reduction principles, if you can get somebody to cut their drug use in half and get them stable, somewhere to live and a job, as opposed to living under a bridge in a tent, having health issues, then that's a win. Okay. In the world we live in now, that's a win, right? If you can at least get them to that spot. All right, we've been over that. Okay, this is an important part. People ask, do people graduate the LEAD program? No, you don't. Well, you can, if you want to, some jurisdictions have a graduation party. Okay, you've met your goals or whatever, but you don't really graduate. We like to say lead for life. I usually like participation. Why is that? Anybody? No? Why would you keep somebody in there for life? Because relapse is part of recovery, right? Gosh, you know, I'm a cop. I knew this. All right. So relapse is part of recovery. We've had folks relapse 5, 6, 7 times. What happens is when they can pick up that phone and call their peer or call their case manager, who they trust, who's been working with them on their timeline, who they built a relationship with, that relapse is going to be significantly shorter or just like right then, the next day. Otherwise, a lot of folks will slip into a full-blown and just go on a 2-month binge and commit crime, hurt themselves and others and all that. So having that lifeline helps. We've had one that he was our model case. He came back after 6 years, got 100% in recovery, job, got his family together, everything, and he just popped back up. Hey, I messed up. I got with my old friends, and we're like, no problem, man. We put you back on the active list. Got him right after about a month or 2. He's back good. He's good to go. Again, participant driven. We kind of went over that already. All right. How it works. Eligibility criteria. This is established by your community. So again, I deal with very red counties and I deal with very blue counties in this state all the time. You can sell this program to anybody. And one big selling point is the chief law enforcement official and the DA are allowed to decide what's palatable to them, right? For example, like Santa Fe, New Mexico, they were like, hey, we have a problem with opiates and they're doing break-ins to get opiates and money. So they decided we're only going to divert opiates. Fayetteville PD, they divert all drugs, anything less than trafficking, all drugs, right? Others are like, you know, everything except for this, everything except for that. Why is it good to just include all drugs? I used to get that when I was starting these programs and I'd go talk about them around the state. The biggest question that I couldn't answer for a while was, why are we doing this now during the opioid crisis for white kids in the suburbs when we had the pill diversion issue? And where were you when Black kids were dying of crack and getting arrested for crack back in the 80s and 90s? And I couldn't answer that question. I was like, well, yeah, sorry. I apologize. That was wrong. Totally racial inequity, big time. So the way, if you don't include all drugs in the diversion program, that's gonna happen again, okay? Because you're gonna alienate different population groups in different geographic areas use different drugs, right? You have to be fair, you have to be equal, right? So plus, that's the first reason. Second reason is next week a new drug come out, right? What are we seeing already? Xylazine, that came out, fentanyl, xylazine, all that. Next week could be something else. So if that happens, then you got to rewrite the policy. You have to do all that, and, you know, good luck. It's easier just to do all drugs, all right? So enough about that. So anyway, what that does though, it gives your community the ability to make that decision. And it's always take what you can get. If you can only get certain things, run with it. And then later on, try to get a little more, because if you show success, which Andrea is going to be able to tell you how to prove, you got to prove success with these programs. If you don't, you're just spinning your wheels. You've got to be able to show on paper, look at this person before and after diversion program, right? This is how much crime. She'll give you the numbers, and it's very, we've got good numbers to back this stuff up. Okay, what I described earlier was in arrest diversion. You can also do social referrals. Like if I see Andrea walking down the street, and I know I've dealt with her so many times before, and I'm like, hey, Andrea, we got this program you might be interested in. What do you think? I can put her in without an arrest, without an arrestable offense. That's called a social referral. Now, lately, we've taken it a step further and started with community referrals, because sometimes, and this goes back to, I know I'm talking about racial equity a lot, but one of my mentors, Ron Martin from NYPD, when I was still in Fayetteville as a captain, he would come and he was really busting my chops. Hey, you don't have any black males on your roster. I was, what do you want me to do, Ron? He was the one for harm reduction at the time. What do you want me to do? I can't coerce them to coming. So the one thing that we finally figured out was a lot of people are not going to even accept a social referral from a uniformed police officer. It's not going to happen. So what we found started working is when the peers with lived experience went out in the field and started referring people, our roster became very diverse. Now we have a very diverse roster there. Before, we got a lot of white female sex workers. For some reason, that was our main clientele. But as we evolved, especially with this community referrals, we have a pretty diverse group now. And now we're very happy with those results. So let me see. Kind of whatever case management and peer support are really the key. This is really not a law enforcement, this is a law enforcement driven program, but once its role in law enforcement has very little to do with it other than making referrals. And honestly, over half our referrals in Cumberland now come from the community. Social referrals, even our peer outreach that are working with lead clients will refer other people they run into while they're working with their clients and do community and social referrals that way. So it's a light lift. Once law enforcement's got it established, most of the work goes on everybody else, which is how it should be, right? Remember the round peg in the square hole? That eliminates that. That's law enforcement's chance to go, you're it. You got it. You got the ball. Put the ball where it belongs, okay? So, all right, that's that. Partnership, here's who you need to start it. Law enforcement agency, obviously, district attorney, probation and parole is good to have. You don't necessarily have to have them to start. You need somebody to do case management. Okay, case management, and you need treatment providers and local managed care organizations like we use Alliance in Cumberland. We've already gone over that. You can establish that for your community. Now, Andrea's going to go over how to make this stuff look impressive so you can sell it. And by the way, I'm happy to help any of y'all. I'll leave some cards behind and my information will be here.
All right, thanks so much, Lars. Yeah, so I want to make sure we all get out of here on time. So I'm just going to kind of cruise over the first section and get to a resource that we have developed at the North Carolina Technical Assistance Center, which I am privileged to work with as part of my role at NCACC. So first, well, the resource we developed is based pretty much entirely on experience from people like Lars, and then also on the findings of an evaluation that was conducted a few years back on North Carolina LEAD programs. So y'all may be familiar with this. It was conducted by Duke, looked at 4 sites across North Carolina. Very much encourage you to check out the report in full because it's got a lot of really interesting details. But to keep us on time, I'm just going to actually cruise ahead here and how to get started. Okay. So do want to just quickly mention what Lars was saying, the importance of kind of collecting programmatic data, not only for continuous quality improvement to really show what these programs are doing. You know, it's a great way to get buy-in. It's a great way to kind of show that the investment is worth it. So we are the North Carolina Technical Assistance Center. It's a collaboration between 4 organizations that you can see up here. We have pretty diverse expertise and experience, and we brought that expertise and experience together to develop a handbook for developing pre-arrest diversion programs in North Carolina. It's really meant to be a kind of a step-by-step guide and reference for anyone interested in starting a program or anyone who has a program and wants to kind of just see like, is there anything we can do to kind of adjust it, make it better. So we go everywhere from kind of key talking points when you're trying to build stakeholder relationships, all the way through developing protocols to evaluation of your programs. And we have some downloadable templates for policies and forms that you can take and adapt to your community. Also want to encourage you to check out, as Lars mentioned earlier, the National Lead Support Bureau website. They have so many great resources there. Also, it is focused on the LEAD model, but I think there's a lot there to kind of tap into and that any diversion program can really learn from. And you can also reach out to TAC. So you can scan our QR code here to find our website that has technical assistance resources, and also you can reach out to us directly to get personalized support, or you can email us at that email address up there. So thank you so much for your time. And that's how to get in touch with us specifically.
Hello. Thank you so much for your presentation and for all y'all sticking with us through all the strategies that are included on the list of my dream list. But I have the great pleasure of just introducing you all to our NCACC president and Perquimans County Commissioner, who just wanted to say hi and thank you. And then Ashley Worth from DHHS is going to wrap us up. So.
How's everybody doing? Well, just for the record, I have to confess that I am a drug dealer. The state of North Carolina gives me a piece of paper that says I can do it. So that's the only difference. Now, I'm a pharmacist in a hospital. I've been working in Chowan and Bertie hospitals for many, many years. But I just want to take a minute and thank you for being here. I appreciate the fact of what you guys do every single day. It just pains me. I'm proud of this association's connection in this space, that what they've done. The governor, when he was Attorney General, and our association and others were very involved and networked together to try to really move into trying to work in this area and improve services and things around the state. And please tell them I made a comment, and I do appreciate all that both of y'all do for the citizens of North Carolina. But you guys are the boots on the ground and involved in this on a local level. And we've just got to figure out how to continue to expand this stuff. I'm in Perquimans County, out on the coast, northeastern North Carolina, close to Tidewater, Virginia. And it just pains me that we just still have not quite got together, because we have to do everything across county lines. It's not, we're such small counties and limited resources. The opioid money's great, but it's going to come in over 18 years. And for a small county, to do things of significance, we have to cross lines. And we've got to find ways to do that in the rural parts of our state. So I appreciate, again, I just wanted to come down and we've got another forum this afternoon. And I just wanted to come thank you so much for what you do. The impact that you're making on people's lives and changing lives is awesome. And I really, really thank you. So, but anyway, just wanted to come down and thank you for being here and participating.
All right, can we get a big round of applause for all of the counties who got up here and told us about all the things today? Thank you to everyone who joined us, whether in person or online. Thank you to all of our presenters and panelists, our friends at UNC IPRIC, NCACC for helping with today's meeting, and for the amazing space and food. Just for your awareness, the next OPDAC will be held on June 12th from 9:30 to 12 p.m. That will be virtually only. and registration and topic will be announced soon. So anyone who joined us today, you are welcome to return after lunch on your own to join the North Carolina Association of County Commissioners Presidential Initiative Forum on Healthcare Access at 1:30 p.m. Different time, same place. Thanks again.
Yeah, but. Okay, I was like, I get my